So hello everyone and welcome to the event, Public-Private Healthcare, Can We Find the Right Balance? Thank you for joining us here in person in Vancouver and online across the country. My name is Andre Picard. I'm the health columnist at the Globe and Mail, and I'll be your host and moderator today, along with my colleague Andrea Wu, who will join me on stage shortly. To begin with, I'd like to acknowledge that we're gathered here on the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. The purpose of a land acknowledgement, beyond the obvious, is to get us to reflect on our role in reconciliation, both individually and collectively. At a health-related summit like this one, I'd like to urge everyone in the audience to consider why Indigenous people in Canada have such poor health outcomes and what we should be doing to correct that inequity and injustice. And we'll touch on that a little bit today. I would like to now welcome to the stage Bruce Robinson. He's a Nisga'a elder whose name is also Grizzly Bear with a Big Heart. Elder Robinson is a family support elder and cultural advisor for the Vancouver Aboriginal Child and Family Services Society and for the Urban Native Youth Association. We're honored to have him here today to open our conference.
OCM, Sim Gigat, Sigadamana, We Lulayam Gals Nakigunsnet, Wilps Nislishian from the Lachgibu tribe. Can you say that? Lachgibu. Yeah, no, you guys are all a wolf. But it's an honor to be here today. You know, it's in that understanding when we gather like this, there's a lot of power in this room. And that power comes from within our spirit. When we gather like this and be able to make a difference in who we're working for, that's where the power is. We can make a difference for all the ones that we're here to help. It's the understanding of each other's, the understanding of who we're helping in a good way. I work in the downtown east side. What our elders do that bring into the Western medicine is spiritual. Spiritual. We touch the spirit of the ones we're helping. I'm going to sing a song and say a prayer. And as I sing my song, you pray in your heart in your own way for the things you're looking for yourself, for your family, or anybody that you know that needs it right now. Because when we pray together, it's powerful, very powerful. And I always pray for Mother Earth, because she sustains us. She gives us everything that we need in life. Just like that banana bread out there. But it's in that understanding that, you know, with a good heart and good mind, and we can all work together in a good way to make a difference, to make change, to make change. You great spirits, grandmothers, grandfathers, so grateful for today, so grateful for everything you have given us in our lives, so grateful for bringing us together in a good way with a good open heart and good open mind. I ask that you bless everyone here in this sacred circle. Bless everyone. Touch our hearts, touch our minds, and touch our spirits. To empower us to go through life in a good way. To empower us to see the beauty that is within us, our soul, our spirit. To empower us to see the beauty that's all around us. And to empower us to heal ourselves. To empower us. Bring all the good things into our lives. And bring all the good things into our families' lives. Bring all the good things into our homes. Bring all the good things into our work. Guide us well through life. Guide us well in all the good things we're going to do for ourselves. Guide us well in all the good things we're going to do for our families. And guide us well in all the good things we're going to do in our work. I ask that you join us as one throughout Mother Earth. Join us as one in soul, heart, and mind, so we can uplift each other's, have good understanding of each other's, to bring love amongst each other's, and to bring peace amongst each other's. Bring harmony amongst each others, so we can all walk together in harmony in a good way, and to walk in harmony with our beautiful and loving Mother Earth. Mother Earth, please forgive us for anything we've done to harm you in any way, Mother Earth. Please forgive us. And be kind and gentle to us when you bring back balance in this area, Mother Earth. Be kind and gentle to us. We love you and honor you, Mother Earth, for the sustenance of life. We love you and honor you, Mother Earth, for all our lives. So grateful for the people of these lands and the ancestors of these lands, which is the Coast Salish people. So grateful for all our ancestors, for without them, we wouldn't be here today. Great spirits, grandmothers, grandfathers, guide us well in this gathering. Guide us well to bring all good changes that we need to be able to help in a good way. Guide us well, empower us, bring all the good things. parents, I see them. Thank you, great spirits, grandmothers, grandfathers, all our relations. I always forget. I have to really hurry when I do this. They only gave me 3 hours to do that. Can you believe it? You know, but it's that understanding of laughter, right? Because in how it can make you feel, right? What is health? Health is just feeling good about yourself, right? Because it's in that understanding in how, right, when you feel good about yourself. Believe me, it's been 35 years since I stopped my addictions. 35 years. Man, and I'm still going through my healing journey. But it's in that understanding that, you know, private, right, our medical system, we have to be so grateful for it. You know, because when you go to the hospital, right, if you go down in the States and you go to the hospital there, be thousands of dollars. So the decisions that we make today also affects your children, your grandchildren, and all the ones that are going to be coming. And that's why I always say, like, you know, what are you going to do for Mother Earth? What are you going to do for Mother Earth, for your children's children's children? What are you going to leave them? It's the same thing in the decisions that are going to be made, whether it be private or the system that we have now. Because it's that understanding of that. And I really appreciate all of you. I really appreciate all of you. Thank you. Thank you.
Well, thank you very much, Elder Robinson, for that very powerful and empowering message. We raise our hands in thanks to you. Thank you. And now let's turn our attention to today's program. You may have heard that Medicare is in crisis, that the Canadian healthcare system is crumbling. 1 in 4, 1 in 5 people don't have a family doctor in Canada. Emergency rooms are closing with increasing frequency. When they're open, ERs are overflowing. People are being triaged in parking lots, treated in hallways. It can take 8 hours to get an ambulance, weeks to get results of a lab test, months and even years to get a referral to a specialist, never mind surgery. Doctors are burning out. They're closing their practices. Nurses are leaving in droves. Care aides are jumping at the opportunity for better work at Tim Hortons. We're kicking people out of hospital and sending them to nursing homes against their will. Long-term care homes have become killing fields, as they were during COVID. We're surrounded by this natural beauty, but you don't need to look very far from here to see the ravages of the toxic drug crisis and homelessness, just down the street. Clearly, structural changes are needed. While we already spend a lot of money on healthcare, about $344 billion last year, there's still a lack of resources. Or at the very least, money's not in the right places. Some say the solution is a massive injection of public funds. Others believe we need more privatization. Today, we're focusing on that question, and we're doing it on BC, focusing on BC in particular, a province that's been at the forefront of this debate for years, decades even. In a moment, we'll hear about the long court battle waged by Dr. Brian Day, culminating in a Supreme Court decision. We'll also hear about BC patients being sent to the US for care because of the long waits for cancer care here at home. And we'll also hear some middle ground, some mixed messages, collaborators who work with private and public systems at the same time. And of course, we'll have patients sharing their all-important perspective. About 70% of our spending in Canada is public, 30% private. Provision of care is a little more difficult to figure out. At least half of all health services are provided privately, but only a part of those by for-profit providers. It's a complex landscape. I think, though, if there's one thing we all agree on, it's that Medicare can't pay for everything for everyone all the time. Similarly, there are some services that are not appropriate to fund or deliver privately, ever. So one of the central questions we're going to try to address today is this: what's the right mix of private and public provision of care? What's the right mix of private and public payment? Another is the all-important equity issue. How do we ensure that we uphold the fundamental purpose of our Medicare system? No one should be denied essential care because of an inability to pay. That's the ultimate Canadian value. To dive into these questions, the Globe and Mail, in partnership with the Canadian Medical Association, has embarked on a series of events like this one. Vancouver is the third in a series. We visited Toronto and Montreal, and in January we'll be in Halifax. Each of these events has a bit of a regional flavor, but they have the overall debate that's countrywide. We're bringing physicians, nurses, nurse practitioners, patients, advocates, academics, entrepreneurs, all of them together to discuss what greater involvement of the private sector might look like, what it means for patients, quality of care, access to care, and Canadian values. But we want this to be a conversation, not a lecture. So we'd like to hear from the audience throughout the day. Healthcare matters dearly to all of us, so please ask questions, share your experiences online, comment, join discussions in the hallway. The networking is just as important as the talks. We also have a few polls in store for you, so please take a moment. If you look at your badge, turn it over, there's a QR code. So whenever we ask you to do a poll, you just scan that, and then you can type in your answer. While we're on technical issues, I should remind you too that this is a bilingual event. There's simultaneous translation. If you need a device, please go to the back. It will be provided. Nous avons la traduction simultanée disponible en ligne et en personne. Alors, on vous invite d'écouter dans la langue de votre choix. On behalf of the Globe and Mail, I'd now like to invite our partner for this event, Dr. Kathleen Ross from the Canadian Medical Association. She's a Vancouver area family physician and president of the CMA, and she'll have a few words and a fancy video for us.
Thank you, Andre, and way to upsell the video. I just want to say thanks to Elder Robinson for opening this discussion in such a deep and meaningful way. Good morning, everyone. Thank you for joining us in these important discussions. Here in Vancouver, we know, as we do across Canada, that we're at a crisis point in the Canadian healthcare system. As a family physician working here in British Columbia, I see the growing hurdles the system is putting in front of patients and providers alike to get the care that we need. Millions of Canadians, over 6.5 million Canadians without a primary care provider. Wait lists for life-changing surgeries and treatments are growing by months, if not years. And shortages in the health workforce are growing and persisting. Many of us are burning out, and as a provider, I feel that quite deeply, but many of us are burning out and feeling like we have no choice but to leave the profession altogether. We know that this stark reality in our healthcare system is that care may not be there for Canadians when they need it unless we make significant changes now. Some provinces and territories are actually considering privately delivered but publicly funded healthcare to try and alleviate the pressures that we have on the public system and expand our capacity. In fact, as Andre has said, we already do have a mixed system here in Canada. But the balance of public and primarily funded public and private funding has been stable for more than 10 years. As Andre has said, it's roughly 70% funded by the public purse and 30% from private. We actually do have relatively high private healthcare spending compared to other countries like Australia, France, and the UK. And a big part of that is because of a lack of comprehensive national pharmacare programs. Canada is the only country in the world where we have universal health care, but we don't have a national comprehensive prescription drug coverage plan. And then on the flip side, other countries like France, Sweden, and the UK all charge adult patients a user fee to see family physicians. In Canada, we don't. And these are just a few examples, and we'll share a few more in the video that you heard about in just a moment. So to that end, the Canadian Medical Association is co-hosting this series of town halls with the Globe and Mail because we believe it is time that we speak openly about the system, what it is, what it's not, and extremely importantly, what we want it to be as Canadians. I want to underpin our discussions with two guiding priorities. The first is that every Canadian deserves equal access to accountable, timely, high-quality services, regardless of their ability to pay. And the second is that every provider deserves to work and thrive in a healthy and safe work environment. At the Canadian Medical Association, we are not taking sides. We're not putting forward a certain position. We're here to listen to what's important to you. We want to ensure that solutions to the healthcare crisis are grounded in the lived experience of those receiving the services, those providing the services, and indeed the policymakers. So please, keep your mind open, share your perspectives, your questions, your concerns, and your hopes for the future. We will pull together everything that you tell us today alongside the past discussions and the future discussions and generate a report that will be shared back to you. And these findings are going to inform our organization's recommendations for policy at a national level so that we can strengthen the healthcare system for everyone. There's no doubt in my mind that we need urgent change, and we need it now. But that change has to be shaped by everyone in the system. Patients, providers, policymakers. This is for our future. So I thank you very much for being a part of this today, and I very much look forward to our discussions. And I think we'll go ahead and roll that much anticipated video. Thank you.
Canada has an aging population, more complex health needs than ever, and not enough health workers. Many patients aren't getting access to the care they need, and some governments are turning to the private sector for help. Do we need a new balance of public and private health care in Canada? Regardless of their ability to pay, every Canadian is guaranteed access to hospital care, physicians, and diagnostic services like X-rays and blood tests. But every province and territory can determine how services are provided and what is or isn't covered by public health insurance. Private healthcare can refer to services that are not covered by any level of government. The physiotherapy you pay for through employee health insurance. Cosmetic surgery you cover out of pocket. Private healthcare can also refer to public health services delivered by private facilities or providers. For example, some governments outsource specialized procedures, like cataract surgeries, to private facilities. You can also get a flu shot at many for-profit pharmacies. Let's look at how access to an MRI scan varies across the country. Remember that diagnostic services are guaranteed for every Canadian, regardless of the ability to pay. But unless you need emergency care, there can be long, very long wait lists. In provinces including Alberta, Quebec, and New Brunswick, paying a private clinic to get ahead of the line for an MRI scan is permitted. Full stop. In Saskatchewan, patients can pay for faster access to MRIs at private clinics. But clinics must match every privately funded MRI with a spot for someone on the public waiting list. Where paying for an MRI scan out of pocket is not an option at all, patients will have to travel to another part of Canada or another country. As of 2022, 72% of all healthcare was paid for by governments, 15% by private health insurance, 11% by patients themselves, and 2% came from other sources, like donations. On average, Canadians spend more than $1,000 out of pocket per year on healthcare. In February 2023, the Angus Reid Institute surveyed Canadians on the possibility of increased private funding and delivery of care. 28% think privatization is a necessary evolution of care. 33% acknowledge the benefits of both public and private care. And 39% are public health care proponents. Join the conversation.
Excellent, thank you. I'd next like to introduce Andrea Wu, who's going to take us through the next part of our program from the Globe and Mail. Thank you.
Amazing video. Just gonna say it, best I've seen all morning. Thank you, Kathleen. Thank you, Andre. Thanks everyone for being here and taking some time to spend with us today. My name is Andrea Wu. I'm a journalist with the Globe and Mail, and I have the pleasure of being your moderator for our first two discussions. As Andre mentioned, we do have headsets if you need anything translated into French, and those are available at the back of the room. My first guest today is Dr. Jason Sutherland, Director of the Centre for Health Services and Policy Research and Professor at the University of British Columbia's School of Population and Public Health. Welcome, Jason. Come on up here. Just before Jason and I chat, we're going to run a brief poll, as Andre had mentioned. So audience members, if you could please open up the polling site. Again, it's on the back of your badges. You can scan that QR code, or for those viewing the event virtually, it is on your screen. The question is, during the past 12 months, have you accessed healthcare in the private sector? The answer options are yes, no, and don't know. Please take a few seconds to vote. So a lot of people here have accessed healthcare in the private sector in the past year. Some questions about the 7 of you who aren't sure. All right, so we thought it would be fitting today to start today's event with a discussion about the Cambie case, which many of you will know as this marathon legal battle here in British Columbia that challenged the very basis of Medicare in Canada. For those who may not be familiar, please bear with me as I try to summarize 14 years into a minute or so. So it was a legal challenge led by orthopedic surgeon Dr. Brian Day, who has run the private Cambie Surgery Centre in Vancouver since 1996. In 2007, the provincial regulator, the BC Medical Services Commission, started investigating the clinic's extra billing practices and launched an audit the following year. So extra billing is when a patient is charged a fee by a healthcare provider for services that are already covered by the medical services plan. In 2009, Dr. Day, along with several patient plaintiffs, challenged the constitutionality of several provisions of BC's Medicare Protection Act, specifically those which prohibit doctors from accepting pay from both public and private purses, that limit extra billing, and that ban the sale of private insurance for services that are already covered under the MSP. They invoked Section 7 of the Charter of Rights and Freedoms, the right to life, liberty, and security of the person, essentially arguing that it's unconstitutional to prevent people from paying for faster access to healthcare when wait times in the public system are too long. The defendants, the governments of BC and Canada, and intervener groups argued that the case was not about healthcare at all, but about corporate greed, and that if the plaintiffs won, this would create a two-tiered healthcare system that would destabilize public healthcare in BC, leading to longer wait times and upend the very foundation of Medicare. The trial began in BC Supreme Court in 2016. The case was dismissed in 2020. In his judgment, Justice John Steeves said that the provisions do not deprive the right to life or liberty of the patients, but that some were deprived of the right to security because of the harms caused by excessive waits. However, he ruled that this deprivation was in accordance with the principles of fundamental justice because they preserved the sustainability of the universal public health care system. Dr. Day appealed. That was dismissed last year. The matter was taken to the Supreme Court of Canada, which last April refused to hear the appeal, closing the door on this very long legal saga. Dr. Sutherland, So in the context of this case, when we say private healthcare, what exactly are we referring to? What was on the table?
I think what we're referring to is the delivery of surgical services that are non-urgent in care. And that would rule out discussion around cancer-related services or emergency surgery for cardiac events, things of that ilk. Now, privately delivered care is, there are two types of flavors generally. The one is privately delivered surgical care that is funded by the government. The other is privately delivered health care that is privately paid for. And that's almost like a pay-to-play type of surgical services. Now, the Cambie case referred to the second type, where it's a pay-to-play to jump the queue to access elective surgeries, so non-life-threatening surgeries, more quickly. Now, bear in mind that these kind of services, privately delivered, have been publicly funded in a number of instances across Canada for many years. There's the Shouldes Clinic in Ontario, here in British Columbia, and now Alberta. Bulk purchasing of cataract surgeries occurs in privately delivered surgical centers.
So what did the court's rulings mean? What was the impact of this being shut down?
Yeah, that's a really important question, Andrea. It is around thinking about, now that the court has ruled its judgment around the private pay for elective surgeries, what's the impact for Canadians waiting to access healthcare? So in the short term, that means that Canadians can't pony up in their own province to access elective surgery in their local hospitals more quickly. There are instances, of course, of provinces being able to travel to other provinces, or residents traveling to other provinces to receive those services. That's primarily related to when we see these instances for orthopedic surgeries occurring fairly regularly, although it is reserved for those of high socioeconomic groups. However, what it means right now is that for most Canadians, we are going to be living for at least the short and medium term with the system that we have now, whereby we're registered on the wait list, we go through our gatekeeper of primary care, we take our turn and wait on the wait list, so that there's no significant impact on the delivery of elective surgery care due to this decision.
So while the case was dismissed, it did lay bare the very real pressures on our healthcare system. The courts cited expert evidence that ruled that duplicative private healthcare was not the solution. It could actually lead to longer wait times in the public system. But if nothing else, did this case not underscore the urgent need to address these issues?
Yeah, this is something I'm very passionate about, and it gets me a little bit upset because I think that the Cambie decision, and I will remark that wait times are not new in Canada to access elective surgeries. They're not induced by COVID. They might have been made worse by COVID, but they pre-existed certainly for at least tens of years. The government, owing to the Cambie decision, in my opinion, had an opportunity to really weigh in with innovative policy solutions to try and address the problem of access to elective surgeries. This could have meant applying almost like what best practices are for accessing ration services. They could have had centralized triage. They could be centralized triage, centralized waitlist processes rather than locally led. They're not even applying or mandating the policies that are trying to expedite access to elective surgeries. At a system level, some provinces could have moved towards paying hospitals differently to create a financial incentive to improve the access to elective surgeries. So for example, about 10 years ago in British Columbia, there was a brief experiment with paying hospitals to do more and do it more quickly. These were rolled back and ultimately halted. In Ontario, they persist in a form as well, where hospitals have an incentive to do more to receive more income. So there is a lot that governments could be doing to try to improve access to elective surgery, but for very complex reasons and health system reasons and working across the different stakeholders, including limitations on health human resources and building up training programs, they haven't done so. So in my opinion, there are a lot of ways that government could make serious moves to improve wait times, but at this time haven't done so. So for another example is that patients waiting on the wait list right now, they're treated equally, but everyone on the wait list is not equal. Some experience excruciating pain, while others simply want to be able to pick up their grandkids. So there's no differentiation between those two, and there's no prioritization associated with patients' symptoms, their anxiety, or their gain in health, so that there could be some policy initiatives to try to improve access to healthcare for those that might benefit more or need surgery more quickly.
The initiative that you referenced where government would pay hospitals to meet wait, is that the wait time guarantees in mid-2000s Harper government initiative?
No, that's not the wait time guarantees. I'm actually referring to the limited implementation of activity-based funding, whereby if the hospitals do more surgeries, they're remunerated more by the provincial government to do those surgeries. So thereby creating an effect whereby doing more means more revenues for the hospitals, ostensibly to increase the surgical capacity and throughput of elective surgery cases. And you did see that this, and many, many countries across the OECD group of nations have this type of policy in place to try to induce provinces, hospitals to do more. So there are initiatives. Likewise, though, the initiative that you're referencing under the Harper government certainly did do a lot to improve access to elective surgeries then as well, too. And certainly some of the benefits of those funding are still with us today, like wait time reporting across all of the provinces and understanding what had previously been hidden and unobserved to Canadians, how long they're going to wait and wait for what. We now have that public reporting.
We're at an event about public and private healthcare, and if we can strike a balance, if there should be a balance, do you think there's a role for increasing private healthcare?
Well, there's certainly, I think that what we have now is a situation that appears with changing demographics, with Canadians aging, living longer, that demand for elective surgeries is going to increase. There is no doubt about it. We have shown through our actions and government's actions and provinces' ministries of health to not be very resilient in matching supply with demand, so that we have this imbalance between supply and demand that's induced these long wait lists. There are clearly opportunities for us to do better. We're opting not to do it, but here we are talking about maybe we should substitute private care. With the advent of COVID, it certainly did illustrate that the Canadian healthcare system was probably not very resilient or robust due to these system level shocks like COVID. And in fact, many, many hospitals across Canada closed their surgical rooms, operating rooms for elective surgeries because they were non-life threatening. Having the outlet or a pressure valve of a private system might have helped alleviate some of the access issues during future shocks. So I think it's nice to have almost like a pressure valve that the Canadian provinces can rely on. However, we have to think about if we create the pressure valve of having a private delivery system in some form that runs parallel to the public system, what are its functions, responsibilities, and how do the provinces keep it alive? Could they rotate different surgical specialties through it to increase throughput? Would they all be publicly paid instead of private pay? I think these are open questions, but I think having a robust alternative that could complement the public system and clearly its limitations that we're not being able to work around suggests that we have opportunities. Also, part of the issue associated with elective surgeries is the gatekeeper model of primary care. So right now, it's largely unobservable to know how long patients are waiting from their primary doc referral into seeing their surgeon. If we're going to work through the surgical episode, we should be working upstream to address all of the issues of the surgical episode and work to create that episode of care, which can certainly involve private providers, provided that we're not just treating those patients with higher socioeconomic status, with more means to be able to jump the queue instead.
So we should have time for one or two questions at the very end. I just have one more question for Dr. Sutherland, but if anyone did have any questions, you can sort of formulate those now. Going back to the Cambie case, I thought it was very interesting that the courts acknowledged that denying faster access to care may violate some charter rights, but deemed it a reasonable limit because it helps sustain public health care. So in other words, the court was considering the greater good.
Yep.
How do you view the balance between individual rights and the broader societal goal of equitable health access?
Yeah, it's a very, very complex and loaded question.
You could answer that in about 30 seconds.
That's right.
You have more time.
So certainly the Cambie decision laid bare that at the time of that decision, the public good of having the access to elective surgery outweighed the creating the private system. I think as things evolve with increasing demand, and if governments aren't good at matching supply with demand in the future, you're going to see that balance changes if we have more tens of thousands and hundreds of thousands of patients waiting longer and longer, that there'll be increasing calls. So this is more like an open call for policymakers to sort of step up, to make these interventions, to work through the elective surgical episodes before we get to the case where we see cascades of future lawsuits chipping away at public access to health care.
All right, we do have some time for audience questions now. If you have a question, please raise your hand and someone will run a microphone over to you. Let's go over there.
Thank you. Thank you for your perspective. How do you address the HHR question? There is a finite number of resources available to provide care, regardless of who pays for it. How do you address what happens when the private system needs to be staffed by individuals coming from the public system, and then the downward pressure that places on the public system to address the private?
Yeah, I don't disagree that we are in a tough spot right now with regard to availability of health human resources to provide additional elective surgeries. There's no doubt about it. At the same time, I do know that there is additional capacity of surgeons who are underemployed or not fully employed. So it depends what we want to achieve with the resources that we have right now that are publicly funded, including surgeon services that are not being used. So in the case of the nurses and of the surgeons and all of the specialists like anesthesiologists and all of the support teams around hospitals, we need to think medium and longer term of how do we build the training pipeline to address this in the future, starting with the universities for nursing and surgeons and anesthesiologists, but all the way through to work through it. And in the tight timeline right now to address it, I think the focus is really important on HHR, but we can also do things that we know to work to reduce wait times that we're not doing right now. So I think it's a bit of both.
Another question in the room.
Yep. Thank you. I'm Tom Cox from the University of British Columbia. I'm a medical ethicist and geographer. Just two quick points. One, when we talk about elective surgeries, most people think of rhinoplasty. Remember that these are not elective surgeries, but these are non-emergency surgeries in areas where people have strong deficiencies of mobility, increases of pain, and it's very different from what most people think of as elective. So I wouldn't use elective, I would use non-emergent surgeries. I would also simply point out that you're absolutely correct that there is much we can do and should have done in terms of organizations, but that is separate from the Carter decision, which was appropriate and clear in terms of not creating a two-tier system. We have to go back to '93 when Chrétien made the devil's deal, ceded basically responsibility to the provinces, and began to decrease the amount of federal monies which went into what had been a federal-provincial partnership. So we need to reintroduce that idea and reintroduce the funding necessary while the individual provinces come online with the programs which we all know, well, everyone in this room has things that they would want to do tomorrow, but all of us are experts, of course.
Thank you for that. Is there another question in the room, or Lisa, if there might be anything from the virtual audience?
Yeah, there are a lot of questions in the virtual queue. One viewer asked if worker compensation cases are prioritized, why physicians always ask if it's a workers' comp case, are they going to the front of the line?
Yep, I'm happy to bat that one out of the park. Certainly there are priorities within many of the provinces where workers' compensation, the insurance fund that tries to rehabilitate employees, workers that have suffered work-related injuries. Yes, they are often offered surgical options in the private sector to be able to return to work and become fully functioning, or return to their new normal and become taxpayers again.
We have just under 2 minutes left. We could get to one more question in the room, probably.
Oh, I hate that this is the last one. I
That'll be
was
good.
wondering, what's the worst case scenario if we let market forces go unhindered? What happens?
Well, are you asking me? Or are you generally opining to the room? I mean, it's a tough one.
Yeah, and I didn't want to set a terrible tone at the end of this important discussion. I'm just curious, what scares everybody? What is the nightmare scenario that seems to be holding everything back?
Yeah, that's a fair question about what is the nightmare scenario if we remove all market barriers to a private surgical alternative to the public system. I think in my reading, the fear is that there would be a direct and significant cannibalization of the public system to construct and operate, maintain a separate system for those that can afford to pay, while those who cannot afford to pay are left with what's left.
On that note, we have to leave it there. Thank you so much, Dr. Sutherland.
Thank you.
Thank you for those questions. Thank you. Cheers. All right, so next up we have a discussion focused on BC's backlog and wait times for test, treatments, and procedures, and whether private providers could or should play a greater role in easing delays. Our panelists for this discussion are Lauren Paperney, founder and president of Canada Diagnostic Centres, Tamara Taggart, community leader and patient advocate, Dr. Chris Hogue, urologist and past president of Consultant Specialists of BC, and Dr. Saad Ahmed, family physician and Western director with Canadian Doctors for Medicare. Please welcome our panelists. As they get settled in, we have another poll for you guys. The question is, have you tried to access healthcare in the past 12 months for you or a loved one and were unable to receive care? The options are yes, no, and don't know. Please take a second to vote. Looks like the majority of people have been able to access healthcare that they needed in the past 12 months, but that's not an insignificant amount of people who have not been able to. Thank you for voting. All right, so Tamara, I wanted to start with you. Hello, it's great to see you guys.
It's good to see everybody.
I wanted to start with you as someone who I know has had a lot of interactions with the healthcare system for you, for family, as a very vocal and fierce patient advocate. I wanted to ask you about your experiences, things that have jumped out at you, things that you've heard about.
Yeah, I mean, I was, diagnosed with cancer in 2012, and in 2007, I had a child with Down syndrome. So those are my two main, a mother and then a cancer patient in dealing with our healthcare system. My cancer care was great. It was 2012, and I mean, it felt long to me, but what I see what's happening today, it's quite quick. My experience, the chemo drug I was on, I had a very rare cancer, a gastrointestinal stromal tumor. Not a lot of people know what that is. It's called GIST for short. 15 in a million people get it, mostly senior citizens, and I was 42. So my chemo drug that I was on for 3 years was $5,000 a month, and I didn't pay for it. BC Cancer paid for it. My son with Down syndrome, it's been a different story. It's been more of a negative experience than my cancer care was. Finding non-discriminatory care for a disabled child is hard to do sometimes. Wait lists are very, very long, years in fact. And we've had to pay privately for some things and borrow money from our family in order to pay for things. And then of course I have friends in the current system right now who are waiting 19 weeks for radiation for breast cancer. They're having to wait for mammograms. It is also very hard to have a vagina when you are in this healthcare system. And every woman in this room knows what I'm talking about because, until you have to go to Life Labs or something and swab yourself for your Pap test, you really haven't lived your life. It's really something else. That's where we're at now. So I think it's a mess from a patient's view, and I do not think that we are in a system that has the patient at the center of all decisions. We are way too admin happy, and we don't focus on the patient and what the patient needs.
This is an event about public-private healthcare, whether we need to adjust this balance. Do you have any thoughts on that?
Me?
Yeah.
I think that when you're a patient, you don't care. You need your care and you need it now. And I really like what the gentleman said about elective surgery. I mean, they canceled heart surgeries at Children's Hospital that were elective surgeries. They're not elective surgeries when you have a 3-year-old that has to have a heart surgery. So I don't think that patients care whether it's private, public, what it is. We just want healthcare, and we need access to healthcare. Most people I know do not have a family doctor, and they cannot find one, and no matter how much help they get. And not everybody can go to a nurse practitioner. It's garbage when people say this to us as patients. We're complicated human beings with various problems, and we come with families. And, and women accessing care in this province is even harder because we face more barriers than a man does because we're told various things when we complain about our illnesses. And I don't think that I'm not painting everybody with the same brush, but I don't think that, in the grand scheme of things, a patient that needs care cares where it's coming from or who's paying for it. But I can't afford $3,000 to go have a surgery somewhere. I know that, and I can't do it for any of my kids either. So we need our public health system to be robust, have patient-centered care, and we need it to be more transparent because spending the billions we do and having the crap care that we have, not the doctor's fault. I blame all administrators at the highest level for not thinking about it, right? When you have bureaucrats that have been doing their jobs for 30 years, that we're paying for, and they aren't doing their job, we have the right to ask for the receipts.
You had asked earlier, I believe you are allowed to swear on this panel.
Oh, yes. Well, I'm just warming up.
Chris, I wanted to bring you in next. What is your work experience like, and what challenges have you seen in your practice?
I think the biggest issue right now that resonates with me and with all my patients is the distress in the system. Tamara's just spoken to that. I daily have patients in front of me expressing their distress, often at how long they've been waiting to see me, which, we as physicians, we're constantly trying to manage our wait list to try to get patients in as the urgent patients in urgently, but also those elective patients that we know that are sitting there with less urgent problems, but still important problems that are affecting their daily lives. And we just can't get to them. There's just not the human capacity in the system to get to them. And so we see that distress from patients every day. And then we see the distress amongst all the healthcare workers. And that was magnified for sure during COVID. And unfortunately lingers in a significant way as we hopefully emerge from COVID. So it's incredibly distressing for surgeons not to be able to get their patients into the OR. One of the things that I've been focused on with Consultant Specialists of BC is actually further upstream, just getting patients from their family doctor to a specialist when they're referred. That's where the wait lists are the most enormous right now, and poorly quantified, as our previous speaker said. And we, as healthcare workers, we're constantly dealing with this moral distress that we want to deliver care to patients. We know they're out there waiting to see us, or we've seen them and we know they're out there waiting for their treatment, and we want to deliver it quickly, and we know that their condition is potentially declining, and we just can't get there. There's obstacles.
I think that's a really good point, because we hear a lot about the patient experience, understandably, but also the moral distress of healthcare providers who aren't able to provide the level of care that they want to, or patients, the disease progression is such that, you know, if they had shown up months earlier, the prognosis could have been very different. You had mentioned in an earlier conversation that you had worked in Melbourne, you had some experience with the two-tier system there. What was that like, and what did you learn from it?
Yeah, so I finished my residency in 2008, and then went down and did a one-year fellowship in Melbourne in minimally invasive surgery. And when I finished my training, my core training here, you know, at that stage I saw the elephant in the room, and that our healthcare system probably was not going to be sustainable. That healthcare costs were increasing. We're seeing increasing technology costs, increasing use of disposables and single-use healthcare products, pharmacology costs increasing. And I just didn't see how we could continue as a public healthcare system to fund this. And so before I went down to Australia, I thought, you know, maybe we do need a parallel system. And then I worked in it. And I came back from Australia actually much more conflicted. What I saw in Australia was that with the way their system was structured, I felt that the public healthcare system there was often neglected. I felt that patients often didn't receive the same level of care that they did in the private system. I saw bad patient outcomes that I thought was probably a symptom of the private system bleeding resources and human resources away from the public system, and it disturbed me. So I came back to Canada much more conflicted. Now, we have a healthcare system that's broken. It's not working. We've got all these waits, and so clearly we have to do something. And so I have reservation about two fully parallel systems. I see a lot of pitfalls there now after my experience in Australia, but at the same time, I think we have to be open to novel solutions, and that has to include the private sector, but how we implement it is key. And so I think that's what we have to work on, and this conversation is critical to starting that work.
Lauren, I wanted to bring you in next. Tell us about Canada Diagnostic Centres and what the model of care is like there.
Canada Diagnostic Centres is an imaging provider that's been around for almost 30 years. It provides diagnostic services throughout various provinces, primarily Alberta, Saskatchewan, Ontario, British Columbia, and 99% of it is publicly funded, privately operated. So we have different modalities, ultrasound, x-ray, mammography, fluoroscopy, MRI, CT, and we perform services for approximately 700,000 patients annually a year, where they come to our centers, they have a doctor's referral, our radiologists are in charge of ensuring that the medical services are operated appropriately, and we basically offer a very small wait list in the provinces we exist to ensure that there's timely services.
What do you feel the role of companies like yours might play in helping to ease backlogs?
I mean, we're part of the system already, right? So in areas like Alberta, where there is a robust outpatient imaging system, access to important modalities like mammography, pain injections, ultrasound are much more readily available. So my sense is that a robust outpatient system is something that is beneficial to the healthcare system in general.
I wanted to turn to Saad. Hello. I wanted to ask you your thoughts on the role of private providers in healthcare.
Yeah, I think, so it's really important that, and I think we did clarify this, but just to reiterate, the difference between private providers that are like family doctors and then for-profit, corporately owned providers. So just for, I think, a lot of folks might not know this, but just to clarify, I'm a family doctor, so when we have our own clinics, those are privately owned for the most part. And many specialists will have their own privately owned clinics as well. And you'll see patients, you'll get paid per patient often for the service you provide. And that's kind of pooled in if you're working with a bunch of partners. And that's how you pay to keep your lights on. That's how you pay for your secretary and if you have a nurse. So we already have private provision in that sense. Many family doctors are private providers. They are renting out clinic spaces, and that's kind of how our system works. The question that I think has really come to the fore, particularly with some of the decisions made in provinces like Ontario, is whether there's a role for for-profit providers. Many provinces, the hospitals themselves are also not directly owned by the health authority. They're not nonprofit entities that exist, right? So to kind of answer your question really quickly, as Canadian Doctors for Medicare, we don't see a role for corporately owned, investor-owned facilities. We think there's a lot of incentives that get misaligned and that people can cut corners. I think it's neat, kind of Chris was able to speak to his example or his experience working in Australia, because the international literature, when you look at cross-comparative analysis, does support that. What we've seen over time in Australia since 1997, when they introduced that second tier, where there are private for-pay facilities and hospitals, is that they first started off with a lot of carrots and to try to incentivize people to buy private insurance. And over time, they've had to introduce a lot more legislation and sticks to try to make sure the public system isn't being underserved. But time and time again, that's happened. So in Australia, they've had to really, really try to support the public system and actually legislate time that doctors have to work in the public system, because it wasn't happening that way. And there's a lot of other examples. I think folks will use the example of Sweden. We can talk about that if there's time, in terms of a role for for-profit providers, the examples of Germany, the examples, I think those are better examples in the US, because we always use the US as the boogeyman, but there's way better healthcare systems that are getting more value for money that
Well, this is
we can look at.
this is going to be my next question to you. You had mentioned the international literature. Are there countries that have two-tier healthcare that serve as warnings for Canada? Are there other jurisdictions that are doing it better that might serve as models?
So based on what we've seen, I think Australia is a cautionary tale. And I mean, it's a Commonwealth country, generally similar cultural values, and we've seen a lot of challenges. Now, keep in mind with the Cambie decision, that's really off the table, a second tier of a parallel system. So I think really the discussion we are having and is that role for investor-owned facilities, the kind that Ontario is introducing. I mean, we're already seeing some early signals, in my opinion, CDM's opinion, that's cautionary in Ontario. There was a Freedom of Information request CBC just published, showing that at least what they're going to pay for the surgeries in these outpatient facilities is more than they would pay in hospital. So that's based off just, I think, a couple weeks ago that the article came out. And, you know, Sweden's used as an example a lot by some folks. They still have challenges with wait lists. This is a universal problem, and one that we would argue the things that Sweden is doing right isn't necessarily because they're involving for-profit players in delivering services. Sweden spends more per capita on healthcare. In fact, if Ontario were to try to match how much Sweden spends on healthcare, Ontario would have to pay $40 billion more per year, right?
That's
so
more.
maybe you could buy that kind of results that they're getting. But I mean, Sweden also covered, with that, they cover pharmacare, they cover dental care. They have a different mix. They also hold, I say this as a GP, but they also hold their GPs really accountable for after-hours service provision. In Ontario, there was a Auditor General report that found only 60% of family health organizations were meeting their after-hours service provisions that they were contracted to do, which then obviously puts pressure on the emergency departments, puts pressure on specialists. So, yeah, there are cautionary tales if we look at the literature.
Tamara, I wanted to go back to you and ask what you think the biggest challenges are that need to be addressed for better patient care and better patient experiences.
Well, I mean, I'm a big fan of transparency, and I don't think that the average person understands the bureaucracy behind our healthcare. I mean, that's what it comes down to. There's so much bureaucracy. We blame our provincial governments, and then we blame our federal governments, and then we have all this money, and is anybody breaking it down to see how it all plays out? We can't ask any questions because we get, the same old answer from the same old people. And I just think that, I was thinking about when I was listening to everybody, when you have a child who has a disability and you need care, first of all, you're on your own. And so you don't know that when you have your baby, that you're actually on your own. And so you have to have a family doctor when you have a baby with a disability. Like, you have to have a family doctor or a pediatrician. There is no ifs, ands, or buts about it. So you have to have that access. And they guide you as to what you need to do, because there's no handbook that you get either. So it's all a big mystery. So when they thought that my son might also have autism, I was like, well, what do we do? Well, you go to Sunny Hill and you can get an assessment. It's a 3-year wait for an assessment. 3 years, that's healthcare. And so that's what we forget, right? It's not just going for, to get your antibiotic or whatever. There's some really important things that need to happen for children with disabilities or without. And so you have a choice then as a parent. Do you spend $3,000 to get that assessment privately, or do you wait 3 years and lose out on some really precious therapies and time, and it's all very important. And then, my son is 16 now. He just turned 16, and I just found out at our last ENT trip to Children's that our doctor is retiring, and my son is going to be, easing out of care at Children's and moving into adult care. And I'm like, what? I didn't know that this happens. When does this happen? How does that happen? What does that mean? Does the general system know how to care for a child with Down syndrome? And it's just like, there are so many challenges, and it becomes so frustrating, and it becomes scary. And we don't know what to do, and we don't know who to ask. And if you don't, that's why people use Dr. Google all the time, right? And I always say Dr. Google is an asshole, because Dr. Google does not give you the answers that you really need.
I have cholera.
Exactly. We need those relationships with our family doctors. We need those. They're so important. They are more important than anything else. And I will say one more thing about seeing a specialist, which is a nightmare, we all know. But my daughter has a severe allergy to rice, and it's very rare apparently. And it was a 36-month wait to see an allergist. So she's 15, so I'm supposed to go 3 years without like having an allergist look at her? Like, what do I do about that? I'm taking them to the eye doctor at 2 o'clock today. I will pay money to take them to the eye doctor. It is not free. I have to spend money when I go there and take them. Same with if I go to the foot doctor. Does anybody in the room have a bunion? Do you know what it's like to get bunion help in this town? It's not easy. You wait 3 years for bunion surgery, or you can pay to have it privately done. What would you do if you can't walk because you're in so much pain? I mean, I don't even know if I answered your question. I'm starting to get riled up now, Andrea.
God, to exist in a city with a bunion and a vagina?
Right? It's not easy.
No. Chris, what about you? You mentioned, of course, there are no easy solutions. You thought you had an idea of what we might need. You went to Australia. You came back less certain. Do you have thoughts on changes that might be helpful here?
Yeah, I think there's a number of things we need to do, and we have to deal with short-term solutions first, and then be looking towards the longer term. In short term, I think we have opportunities to work smarter right away, and one of those ways may be further engaging the private sector in terms of outsourcing some of the types of care like imaging paid through the public system. I'm not talking about private patients going and privately paying. I'm talking about still public care, but that may be one way. Within our clinics, in order to deal with this wait one problem, or that time from referral to seeing a specialist, there's huge opportunity to improve the capacity of our existing workforce to see patients. Team-based care is just in its infancy right now, and it represents an enormous opportunity to improve our capacity to serve patients with our existing workforce. We need to be making healthcare an attractive profession. Right now, I don't think if I were to go back and look at the system as it is now, I don't think I would go into healthcare. My kids, I followed my parents who are physicians into healthcare. My kids, who have two parents who are physicians, say there's absolutely no way they're going into healthcare. That's a problem. I mean, that's a problem that we have our youth that are looking at our healthcare system and seeing as a debacle and wanting to avoid it in terms of a career. So we need to make nursing and being a doctor an attractive profession. We need to make it an attractive profession in our province because the reality is we are competing for talent. It's the same as any private business. We're competing for talent, and so we need our province to be an attractive place to work, and that has to consider all the economic realities of living and working and running a business in BC. We need to expand training, and government's working on that. And ultimately, if we are going to solve these problems, we need to build strong partnership between government and our physicians and all our allied care providers in a meaningful way where we're actually listening to each other and we're relying on each other's individual areas of expertise and recognizing that and working as a team towards this common goal, which is to make sure that patients are served.
Saad, I wanted to ask you your thoughts on practical solutions that we could implement.
Yeah, I think definitely, as Chris is saying, there's a lot of low-hanging fruit when it comes to the referral process and waitlist management. Tamara, I think just to kind of mention actually, one of my primary practices is I work with people with really complex disabilities, and we are starting to see a lot of folks who are aging out of the pediatric system, entering the adult system, which is nowhere nearly as patient-centered or coordinated as the pediatric system. You know, much less like oftentimes with the PED system, you go to the one building, everything's there, everything's taken care of, and then you come out to the adult system and it's like 6 different services in 6 different parts of the city and 6 different referrals. And so, you know, my poor secretary, I had to tell them at one point, I was like, she needs more time because she just has to follow up on every referral. And the referral system's insane.
It's ridiculous.
Like she's faxing stuff and then...
Who faxes?
Well, banks and hospitals.
But that's my point.
Yeah.
It's like,
So And so she'll send the fax for me for a referral for one of my folks who has a very complex disability. So even just finding the particular specialist who deals with that takes some time. And then they might have a really long wait list because they're burdened, and then they might say, hey, try this person. So then she calls 2 weeks later to make sure that the fax was received. And so even just getting that fax into the door itself takes time. And I know the province has the digital health strategy, and they're planning on trying to have like an actual digitized way to get referrals, and so people can kind of confirm that they've been received instead of secretaries calling each other to make sure. But like, there's so much low-hanging fruit there. So I definitely, I would reiterate what Chris is saying, is that in terms of practical solutions, definitely waitlist management. I think there's a lot of opportunity there. Some of the things that I think have already been mentioned is stuff that CDM has recommended, as well as centralized waitlists. Makes a lot of sense, just from like actual queue management. You don't have multiple queues, you have just one big queue, right? So that is a huge, I think, also low-hanging fruit that we need to use in terms of practical solutions. I think I'm really hopeful. This is a large practical solution, pharmacare. Like, I think if we can get that, hopefully by the end of this year, some of the economic modeling suggests we will spend $7 billion less per year. Once again, we have many different insurance companies, but if you had just one massive entity, aka the government, we would negotiate bulk discounts and save lots of money for different folks. So I think that's a very practical solution, because we know 15% of our population can't afford their medications and they don't take them. And that leads to all these downstream complications. The amount of people that I have who show up who haven't taken medications. I used to do a lot of Emerge earlier in my career, and you just see those complications clogging up the system. So yeah, there's a lot of low-hanging fruit and some really big, dramatic change that we could make.
Lauren, do you have any thoughts on the path forward?
No, I mean, I think that, hopefully what this conference is trying to do is that we need real discussions about it, right? I mean, the notion that which I am, a non-physician, doesn't care about patients and doesn't want to have the best healthcare services provided, I think it's a fallacy. I think that in our organization, the radiologists run the entire operation of the facilities. Investment in surgical centers and in diagnostic imaging centers are very, very expensive. The risk systems, the technology behind the information systems, even behind when a patient comes into a center and that information of the ultrasound has to be given to a referring physician, is enormous. So I think there's a place where we can have a publicly funded, robust system that is assisted by the private sector, and I think it can work, and I think it does work in jurisdictions around the country, around the world.
Thank you for that, all four of you. We have about 8 minutes left, so we can open it up to audience questions. We have some microphone runners coming around.
Thank you, and thank you for your perspectives. My name's Alan Lowe. I'm ED of the Medicines Access Coalition BC. I'm also a pharmacist, and I'm also a clinical professor at UBC. And just with a few things, I'm going to have you consider a few things, and I do have a question for you. But with Dr. Ahmed, I agree that everyone needs access to medications. We have to be careful about moving to a national system, because we've just been saying all the problems with a publicly funded system. Guess what? A universal national system means a publicly funded system. And so if you go bulk buying, that means a whole bunch of companies that aren't going to get the contract are going to disappear from Canada or not produce that drug. The same way that we have this mass exodus of healthcare workers, same thing's going to happen, so we have to really carefully look at it. And I want to give you an example to consider. We've talked a lot about the surgery waits. We haven't talked about the drug waits, and thank you, Tamara, for mentioning the cost of the drugs, because they're enormous, but that hasn't come up yet, and I don't see it on the agenda. But let me just give you a real simple example, one that I'm quite familiar with. So there's a drug called evolocumab. It's Repatha. It's used in patients who have really resistant and hard to control high risk for cardiovascular effects. We had a patient referred to us that has been waiting for that drug for over a year. If they could pay for it, they'd get it the same day. But waiting a year. I'm told, and this one I know for a fact, that if you apply to PharmaCare for the special authority, they don't even want to talk to you about it until it's been 2 months, because they're 2 months behind on that one. So again, if somebody could pay for it, you get it right away. 2 months at least. And then there's prior authorization with your private plan too. So we already have public-private going on in healthcare when we consider drugs, which is a critical piece of healthcare. We haven't really mentioned it. Yes, we want every drug covered for everybody. In a national system, that would never occur. You can't cover all 6,000 DINs. You're going to pick your drugs. You're going to have a handful like we have in BC that's going to be a formulary list of stuff. And guess what? BC is kind of the have-not province. There's a drug called Dupixent out there. Every province has it covered and listed except BC. So if you go to a national formulary, who's going to pick which drug? And what happens if your drug that you need is not on there? And sorry, this drug that you're applying for, it's $15,000 a year for that cardiovascular drug. It was prescribed by a specialist at the Healthy Heart Clinic, which they waited many months to get into to begin with. Then they got prescribed the drug, and a year later, they got referred to us as somebody else. There was a delay. We're pretty on top of it. We got that patient started in 2 weeks. But the reality is there's a wait list for drugs, even after the wait list for the specialist, even after the wait list to see the GP who referred you to the specialist.
Luckily, you're posing this to someone who looks at drug shortages
and then there's drug shortages. Exactly. So if we go to a national system and we select some drugs, we're going to run out. And the ones that aren't covered, your options are going to disappear from Canada, because why would you make it if you're not selling it? So you'll drop it off. So yes, we have 42 chemicals that reduce your blood pressure. If we pick the 5 that we're going to cover, the other ones are going to disappear. And then if you run out of the 5, where are you going to go? You've got those 5. You're going to import it from another country, like we outsource our surgeries down to the States or wherever. Anyway, something to consider. The question is to the panel, and either any one or all, what are your thoughts about a universal pharmacare system where you're going to convert our public-private to a mainly public kind of coverage system? And how will you avoid all of these public phenomenon issues? Because again, I'll refer back to, if I could pay for it, I'm on that drug today, the same day I get the prescription. If I'm going to get it publicly covered, I'm sure there's going to be hoops, hurdles, speed bumps, you name it, to slow me down to get that drug. Because everybody wants to make sure the specialist is absolutely correct or the GP is correct in prescribing it. Because Dr. Ahmed, you will have filled out forms that you don't want to spend your time filling out, because that's not the best use of your time. Yet the system's going to second guess you and say, you really need that drug, Dr. Ahmed? That patient maybe can use a different one. Did you use these 5 lower costing versions first before you choose this one that is higher cost and possibly more effective? But that's not the best use of your time. So the question again, how do we make it if we're going to move to a publicly covered universal drug coverage system? Can we do it right when we already have public-private in this funny balance? It's completely legal.
Jeez,
right?
we only have like 3 minutes left. You're killing me.
We are running.
I don't know what the answer is. I pass.
I would gently push against that discourse. I'm going to be pretty blunt. I think that's what pharmaceutical companies want us to believe. And it's what killed the PMPRB reforms, which would have saved this country billions of dollars, that pharmaceutical companies threatened a capital strike and that they would move out their manufacturing facilities and their R&D facilities. That's already happened for 30 years. We pay, amongst OECD comparator countries, more for even generics and brand name drugs than other countries do. And so, you know, this notion that putting us on universal pharmacare, people will still be able to pay for drugs if they want to buy it outside of universal pharmacare. People will still have access to supplemental insurance. There's just going to be a national formulary. Like, do I need access to every single ACE inhibitor? Probably not. Like, you can just have your Ramipril and a couple of others, and then if there's something that's really that special, you could go through special authority. I don't really have that many problems with special authority. I love this province for the fact that it covers Dexcoms for my wife who has type 1 diabetes. And with this continuous glucose monitor business, has really changed the game for a lot of people. And takes me like a week to get it back. I just fill out an online application. So there will be some, like I've dealt with private insurance that makes me go crazy. Like forget the special authority.
We fought for Dexcom coverage. It took several years.
Yeah.
Other provinces had it before BC. Several years
All right.
before Dexcom came to BC.
Yeah. So
right, I'm
definitely, I know we're at time, and we can discuss it as well. Yeah.
I'm going to take another question from the room. Please try to limit your comments. We are very rapidly running out of time. There's two questions.
I actually have a question.
Yep.
So this is for Saad and Chris. Saad, you were mentioning outsourcing to hospitals in Ontario and the CBC Freedom of Information request, and there was that showed actually that Ontario is paying up to 3.2 times higher for those surgeries in private for-profit investor-owned clinics than in public clinics. So I was wondering if you could speak to the impacts on the public system for the vast majority of people who have to rely on the public system when the public system is paying 3.2 times higher for those surgeries in the for-profit system.
Yeah, I mean, it just means less money for other things when you're paying that much more. That's really all it is. We've seen, I mean, the UK experimented with this. I know we're at time, but it was called independent sector treatment centers in the early 2000s. And they were actually investor owned and private equity financed. Didn't really make a huge dent in the wait list in the NHS. Most of the post hoc analysis suggested that there were worse outcomes for the public system. I mean, I'm not a surgeon. We have a surgeon here who could also talk about.
My comment would be that's a lesson that we need to study and learn from. I don't think that should close the door to continuing to explore engagement of the private sector and provision of publicly funded care. And there may be lessons learned from that experience that allow us to implement it in a smarter way here in BC or across Canada going forward. So it's all information that needs to be looked at with smart people in the room who are motivated to achieve the same thing.
So we should be wrapping it up, but I will take one more question if you can promise to keep it succinct.
Okay, I have 3 points. I'm going to first emphasize. No, they're very important.
It does have to be succinct because we're cutting into people's lunches. So one question, if
what's
possible.
more important, healthcare or lunch? All right, I empathize with Tamara. I lost my older sister 2 years ago to breast cancer, and it took 6 months for a diagnosis after her spending 3 weeks in neurology at VGH. Number two, my younger brother just retired as senior counsel at Health Canada in Ottawa in the Aboriginal Affairs Directorate. And he said the problem lies and the power lies with ADMs, Associate Deputy Ministers. They're the ones that call the shots. The minister is just talking points, all right? And then later on today, I'm going to hopefully talk to Dr. Matthew Chow because I went through my MLA, Mr. Aman Singh, who's a lawyer, and he went through a bout of cancer. And we talked about the TELUS Health Network, where I told him about it, and he scheduled a meeting with, I don't know if he scheduled a meeting with the in-house counsel at TELUS, but he went over there to plead the case that healthcare is sacrosanct, as I'm originally from Quebec, and it cannot be touched. So, you know, with the way that TELUS is portraying itself, not only through telecommunications, but through the TELUS Health Network, what is the end game, right? And it shouldn't be that way. All right, thank you.
Thank you. All right, we have to leave it there. Please join me in thanking our panelists, Tamara Taggart, Lauren Paperny, Dr. Chris Hogue, Dr. Saad Ahmed for being here today. Thank you.
Great, so welcome back. I hope you enjoyed the fascinating morning of discussion moderated by Andrea Wu, and I hope you enjoyed lunch as well, which was great, and the view, of course. Next up, as promised, we're going to focus on the patient perspective. I'd like to welcome to the stage Claire Snyman. She's a cancer survivor, author, blogger, healthcare advocate, and many other things. So welcome, Claire, to the stage, and we'll get started. And we're going to do another little poll. We're going to put people to work after lunch. So here's our question for this one. Remember, you use your QR code on your badge, and then you can vote. So the question's a simple one. 6.5 million Canadians don't have a family physician. So do you have a primary care provider? Either family physician, nurse practitioner. And we'll give you a minute to vote. And as you see, there are multiple choices. A lot of people with a family doc, a few with a nurse practitioner, a few no's. Thankfully, no one doesn't know, so that's good. Okay, so I think we have sort of an audience that does better than the general public. That's my sense, because a lot of people in the general public don't have about, a quarter people don't have a family doc. So we have the elite here for an elite discussion. So Claire, welcome.
Thank you.
It's great to have you here. Do you have a family doc?
Actually, I was hoping I could participate in this one because I am very lucky to fit into the family physician bracket there.
Well, we'll add another number.
Yes,
Great.
92.
So we'll put you in the blue category. Great. So I want to start, I want to just, essentially ask you a little bit about your story, because I know your story, or some of it, and it's quite fascinating. So tell me a little bit about your very complex healthcare journey, if we can do that in a minute or two.
Okay, let's get going. So, as you can probably tell from my accent, I'm not born in Canada, so I'm South African by birth. My husband and I then moved to Australia, and we lived there for quite a few years, and then we arrived in Canada, almost 18 years ago, I think. So, as a result, I have experienced 3 different healthcare systems. And having landed in Canada, I obviously would then experience publicly funded healthcare system, and also in Australia, and it's something that I've never ever taken for granted, and I'm very grateful to have been able to do that. I also have also experienced private healthcare, both in South Africa, in Australia, and also in Canada. And so for me personally, this is not a discussion of and or. I find this is a discussion of more issues around sort of choice and also access to care. So I'll take you back to my patient story. So I used to consider myself sort of somewhat of a routine patient until 2010, I think it was. That was the year actually when the iPad was launched. Seems like a long time ago. And that year I was diagnosed with a rather rare non-malignant brain tumor. So rare actually, I think it was 1 in a million people get diagnosed with that. I had a sudden onset of vertigo and migraines, and that took me to the emergency department. And in that exact moment, what mattered most to me actually was, would I grow old to see my son grow up, which now I fortunately am, and would I grow old with my husband? And so I suddenly sort of changed from being a non-routine patient to somebody who had multiple medical appointments, multiple specialists, multiple medications. And
where were you living at the time?
I was living here,
okay,
in Canada.
In Canada.
Yeah, I was diagnosed in Canada. And 2 years after my diagnosis, my brain tumor doubled in size, and I became very acutely ill. And I had to have emergency brain surgery to remove my tumor. And it took me 18 months to recover from that surgery. It was quite impactful. And I actually live with a brain injury now, which is why, I must be honest, I have my cheat sheet here in front of me.
I got one in too.
Oh, good. Okay,
I
we'll
don't
do
have
that together. We'll do that together then. And so even though my brain tumor has probably been one of the most impactful events on our lives, and I say our lives because when you have these health type events, it's not only me as a patient that is impacted by them, but it's also my family. I've also had a lot of other things that have impacted my life. I've had a hysterectomy. I've had multiple kidney stones. I seem to just be producing them at rapid rates. Pity they're not gold nuggets, but they're not. I have had multiple bilateral pulmonary embolisms, so blood clots in both of my lungs. I have an arthritic hip. I have asthma. So I'm just telling you that because I consider myself somewhat of sort of a complex patient, but at the end of the day, healthcare and the healthcare system here in Canada is very much interwoven into my daily life. And I have 5 healthcare specialists on my team, and that is why healthcare is so important to me.
And overall, is the healthcare good?
I can say that on the majority, healthcare has served me incredibly well. There's been pockets of excellence, and there have also been challenges for me in my day-to-day health.
So what's the most challenging thing for a complex patient?
I would say navigation of a very complex system, understanding what that looks like, especially when you go from being a routine patient to a non-routine patient. And I would also say access to care.
Yeah, navigation is a big thing. We have a very siloed system, especially for older people who are you're young, but the majority of patients are older. The navigation is very, very difficult. And, you know, in Vancouver, we say location, location, location. It's all about real estate, but in healthcare, it's access, 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 and we struggle.
Yes.
So I saw you come up to, I was at a conference. I spend a lot of my life at conferences. It was the Canadian Medical Association Health Summit, actually, and you came up to the mic and you said, and I'm paraphrasing, you know, public healthcare is great, but private healthcare saved my life. And I was like, I want to know more about your story, so we invited you here. So tell me about that private healthcare saved my life part of the story.
Absolutely. So I'll go back to that time in my life. As I told you, I was diagnosed with a non-malignant brain tumor. I was put on a watch and wait treatment protocol. That seems really scary. You're diagnosed with something inside your brain that's not supposed to be there, and they say, we're going to watch and wait. And you're like, what? Seriously? What that means is that you have yearly MRIs to monitor your brain tumor. And so I did that. And that was done through my the public hospital near my house. I became acutely ill about 2 years after my diagnosis. Vertigo, migraines that were not responding to my normal medication. My GP was like, this is not right. I went to the specialist. They said I had an ear infection. I then went back to my GP. She said, no, I think you need to go to the emergency department, which I did. She said, I think you need a CT scan. She sent me with a letter, and I went to the emergency department. Unfortunately, I wasn't given a CT scan. I was given IV meds. I came home. My husband was like, did you get imaging? And I said, no. He's like, I just feel like something is wrong here. And I said, I know, but by that stage, Andre, I was tired. My migraine was not going away. This was 2 weeks after it had started. I was starting to lose my memory of what had happened sort of the day before. My husband said, I think we need to get an image of what's going on inside your brain. So I spoke to my GP, and she said, well, you could get a private image if you want to go to the imaging lab downtown. And so we did. We were lucky enough to be able to afford to get a private MRI. And so that's what we did. And let me tell you, I will never forget, and I will always be thankful for doing that, because it showed that my brain tumor had doubled in size and was blocking the fluid to my brain. And I had a condition called hydrocephalus. If I had gone home from the hospital and not sort of followed up on that, I would have gone home, and eventually I would have gone to sleep, and I would not have woken up.
Yeah, hydrocephalus is very, very dangerous.
When it is acute and is obstructive, which it was doing to me, it can be life-threatening.
And are you angry that this didn't do the CT scan in the public hospital?
I was. I've gotten past that. It was taken down as medical error, actually. I did follow it up after 18 months of recovery once I had gotten through that, because I think it's important from a patient safety perspective that we look at the learnings. But when I look back at it, I realized that this was a system error, that there was challenges with communication in a system that was overburdened at the time that I was going in. But for me, what was really important was that I had the choice. I had the opportunity to be able to take the privilege that I had of being able to go and get a private MRI. And I'm eternally grateful that I can and could, because my son is almost 18 and he was 6 at the time. Wow. And I get to see him grow up. I get to grow old with my husband.
And if you hadn't been in BC, another province, you wouldn't even had that option.
No.
And you said, you know, you sound quite forgiving. about this. We learn from our errors, but that's a really high cost to pay for a learning. You could have died quite easily.
Yes, I could have died. I now use my experience in other ways as a patient partner. I also work with health authorities on ways to embed patient experience and learnings into the work that they do. I did go through a lot of counseling as well, so we'll take that because I had PTSD afterwards, understandably so. But I think when we look to see how can we understand and embed the experience, what the process of receiving care feels like, and how a patient's accessing care, I think that's really fundamental. Whether it's public, whether it's private, what does that look like? I think that's essential.
And you said the word choice. Choice is often a dirty word in Canadian healthcare. How important is it to you as a patient?
That's an interesting question, because as a patient, I often feel that there's often quite a lack of choice. As a patient, one often feels very vulnerable in decisions that's sometimes made around you. Tamara often referred to earlier as a lack of patient-centered care in a system that is designed around a system and not around patients. And that often takes away a lack of choice for the patient being at the center of their care. And so choice in how you access your care, what choice is available to you, and what that looks like is often not at the center of the decision. So for me, being able to have choice in how I access my care is really, really important. For me, timely access to safe and quality care are always the key drivers in anything that I do in my care.
The other word you used was privilege. You recognized that you had the money to pay for this. If you were the lady who was serving our sandwiches at lunch, maybe you wouldn't have gone to the private clinic. Does that weigh on you?
Yes, because when I had recovered from my brain surgery and I realized, what if I hadn't been able to afford that MRI? I might not have woken up. And what would that have looked like? Well, I wouldn't have known. And
Well,
so,
we're not sure about that.
but that's the reality is that medical error aside, is how do we go back to the fundamental challenges that we're facing on timely access to care? I think that for me was the biggest learning is looking at that aspect.
So as someone who thinks about this a lot, what should our system look like? How do we get the private and public mix right, which is the fundamental question today? After you answer this, we can all go home because you're going to have the ultimate answer.
Oh my gosh, that's a difficult one. I think for me, I always use the question, what matters most? And that's what matters most to patients, families, and caregivers. And I always add in families and caregivers, because behind every patient, there's often a family, a caregiver, a support person, as I have my husband behind me, an individual who has a brain injury. I need my husband behind me to help me through my healthcare journey. I think asking that question, which is what's sort of happening in these discussions here, is what matters most to the people who are both receiving care, also those who are providing care is really essential to really understanding what this looks like. And it's interesting for me, as I said, having actually received care in 3 different countries. Well, actually, I'll add 4, because I actually received care in the US as well. There have been a couple of instances where I have, Tamara was talking earlier about wait lists. I have 5 specialists on my team. Whenever my GP says to me, well, I think we need a referral to another specialist, my heart literally sinks, because I know what that means. It means a 6 to 9 month plus. My longest wait list has been 2 years. And so what does that look like going forward? I don't know. I don't have all the answers. I've been involved in countless advisory groups, committees, and so forth on this. But I think if we continue to ask that question of what matters most to people, providing care and receiving care on both sides of the coin, I'm hoping that we can move forward.
And as someone with this unusual experience, Canada, US, Australia, South Africa. You've had care in all those countries. What can we learn from that? Who does things well? Who does things badly? What can Canada learn?
I was thinking about this because I know, and I've also read all those OECD papers and all of that, but I didn't want to take it down that route. So I thought I'd pick up sort of two key learnings just from my experience, what it felt like receiving care in those areas. And there were three areas that I thought about. So one obviously is the huge benefit of receiving care in Canada is that I pull out my healthcare card, not pulling out my credit card. And that is of huge benefit to me. I don't even think when I go to the emergency department, which I unfortunately am a frequent flyer. The continuity of care as well that I find in the publicly funded system, and I know we talk about it and we say that there often is no continuity of care. However, when I am seeking care between public and private, within the publicly funded, it is better because the private is still a little bit of an outlier. Yep. I want to talk about visibility and expectations. So, as I was saying, as somebody who has sort of multiple referrals and so forth in the system, when I do get a new referral, there's always this like, how am I even going to track where my new referral is in this sort of cyberspace of referral systems? It's a lot of patient burden and admin. I'm the first one when I get a new referral, I will phone a week after I've given my referral has gone in. But I'm on the phone, phoning that new office to find out where it is, to check, well, your referral is 6 months, and then I put a note in my diary. The patient burden of following up is high, but there's no visibility or clear expectations in the public system of what that looks like for a patient, let alone my care provider. When I go into private or I seek a private referral or imaging, there's much more clear visibility and expectations of what my timeline looks like, whether it's weeks out and so forth. So I think there might be a learning there on what we could look like for visibility and expectation setting for both patients and care providers. And the other thing that I was thinking about is timely access to health information. So as a patient here in BC, I really struggle with getting any of my, clear and timely access to my health data. This is really, really important to me as a patient. It's important to me because it allows me to be engaged in my health and my healthcare, and it's important to me from a patient safety perspective. It's very fragmented, I find. This could be maybe just specific to BC, but I know across Canada there's challenges as well.
It's not specific to BC.
Thank you. When I have, for example, had care in the US, I have a few portals in the US. I know there's struggles with sort of different portals and all of that, but as soon as I've accessed care in the US or I've had imaging, the time from getting my information about my imaging or the notes from my specialist appointment is so quick. And as a patient, and then I'm able to send it on to my provider, which is amazing. So I send it then back to my loop here in BC. So that is amazing because the quality of communication and just having access and timely access to my health data is so important. I can't actually iterate what that is. That interoperability and just getting that information is a huge patient safety issue. So I think there's a learning there as well.
Well, data is so important, and it's becoming more so with genomics, with artificial intelligence, personalized medicine. And we have this obsession with secrecy in Canada, like the state hangs on to the data. That belongs to patients.
Absolutely, 100%. So I think those are some of the learnings that when I sort of integrate between these two areas, I say to people, I don't save for a rainy day, I save for my healthcare. Because they were talking earlier about hip operations and elective, and I don't call it elective, I also would call it non-emergency. I have an arthritic hip, so I know one day that's down the road for me. So I'm like, well, I better start saving for when I can't wait 2 years. I go for cortisone shots into my hip because when my hip gives me issues and I can't sit, I was standing at the back there because eventually I can't sit for too long. I know when I need to go, I go to actually Canadian Diagnostic Services for my cortisone shots, because when it goes, I can't sleep, I can't sit, I can't drive, and I can't walk. I need to have it done now. So when I'm going to save for my healthcare, because that needs to be an option, a choice for me, when I can't wait for 4 months in the public healthcare system.
And I sense increasingly the Canadians are willing to pay some money for their health care, but what they want to know is what is covered, and then let me know what's not covered, and I'll figure that out.
Mm-hmm. If I was a patient that was able to access that through the publicly funded healthcare system, that is where I would go. But right now, I have so many conditions going on, so many medications, so many appointments, and so many specialists, that it is hard for me to be able to manage it all and not know what my timely access looks like when I'm looking at anything between 6 to 9 to 12 to 18 months to get access to care.
Now I'm hogging you. Let's see if anybody else has questions for you. Lisa, is there anything online that's popped up? I don't know where Lisa's going. But...
Stand up so that
okay.
can be on camera.
Okay.
A question from the audience came in about follow-up care, because often when you're more emergent or it's more serious, you do get prioritized, but then as you go along, what's been your experience with follow-up care?
That's a really good question.
How long do we have?
That's a really good question, because one thinks after my brain surgery, when I was recovering, I then lost my balance. And so even my neurosurgeon at VGH was trying to get me into an urgent referral to a specialist to help me, which was 9 months to get in to see that specialist to figure out why I was losing my balance. And so sometimes even though you are deemed priority, you still can't get a priority specialist appointment. And so when you can't drive, you're struggling to walk, and you feel like you're walking on a boat your entire day because everything around you is moving around you and it's not vertigo, you have to make the call and say, what do you do? Or when you can't walk up the stairs at home after your pulmonary embolisms, and you can't breathe or do the laundry or walk down the street, and your urgent cardiology appointment is 4 months, it's really hard to figure out what to do. And so that's where my struggle has been, is even after your follow-up care, when you've had these conditions and you're deemed urgent, urgent is not urgent enough. I'm like, I don't know what the people who have, because I was like, I'm having all these problems.
Like who's
but
ahead of you?
Exactly. Yeah. I'm like, I feel really, really bad for the people who must have massive struggle, or massive problems that are way worse than me. I don't even know how they are managing.
But I think we heard this morning that it's not necessarily who's ahead of you. It may be just someone who's waited 6 years and has a minor thing. We just don't know.
Correct.
Any questions live? Yep. Wait for the mic, because we have people online, they can't hear you.
It's quite a story. I'm curious about your experience in Emerge, that one moment of truth where a doctor said no to a CT. Did you push for it? Did it feel like a systemic failure that you didn't get that scan? Or was it a single physician who is stressed out, overloaded, and making a bad decision?
That's a really good question. So bearing in mind, I'll put you in the situation I was in. My brain was swollen. I was starting to lose a bit of memory and so forth. My husband wasn't with me. Good point. When you are getting that ill, make sure that you take a backup person with you. I went and I did actually ask him. I said, my GP has said I need to have a CT scan, have a brain tumor. She wants to make sure it's, not growing, etc. And he said to me, no, I think we just give you your IV meds and we'll make sure that that's enough. I didn't ask again because I was not in the state to ask again. And I think that is, I've always thought to myself, should I have asked again? But I was like, you know what, that's really hard. Patients are in a vulnerable state. I think I'd asked enough. And then was it the doctor? Was it the system? I don't know. I think I could point fingers, I could do anything. But I did do a complaint afterwards to the College of Physicians and Surgeons, but it was not actually directly to one physician. It was a multiple of errors that happened prior, actually, that led up to the point in time. But what I did realize overall was that a lot of it was actually to do with communication. Some of it was communication between different specialists. Some of it was to do with paper versus electronic. So that, I think, was the biggest overall challenge, was communication.
But, you know, it's hard to advocate when you're scared, you're sick,
exactly.
You don't have anyone with you. Like, it is really essential to have an advocate with you at all times now.
Absolutely, and I think as well it does highlight the importance of the patient voice. I did articulate what I thought. Are we going to do a CT scan of my brain? I've had, you know, and so forth. But that sort of didn't really come to the fore either. So yeah, I do try really hard. I consider myself to be an activated patient. However, when I'm ill, I do know that sort of trickles down, it falls down, it's not as strong as it normally is, and I need to be aware of that.
I don't know where the mic is. We have a question here up front. Oh, you can, yeah.
Hi, Claire. Thank you for sharing your story. My name is Audrey. I organize with the BC Health Coalition, and I want to say, as those of us that aren't providers, that aren't physicians, we are often pigeonholed into this identity as a patient. And I think as patients, when we're in those situations where us or a close family member is in need of urgent care, no one can blame you for doing everything you can to get that care. It's a question of life and of well-being for those we love the most. And so I think that experience is so valuable. I also think about another identity that we all carry, which is that of members of the public and citizens. And as citizens, when I go back to that question you asked, what matters most? To me, what matters most is a strong healthcare system when I need it, or when my daughter grows up and if something happens to her, I want it to be there for her. I want to ask you to a little bit about that identity for you. You're clearly very used to talking from your experience as a patient, and I'm curious how you think of yourself as a member of the public that has an interest in this public healthcare system. How do you think about yourself that way?
No, absolutely. That's actually why I work. I work as a patient experience consultant with healthcare authorities because I have a strong vested interest in the system that we have. I believe I want it to be strong for my son when he grows up, when he has children, because I believe that it can be stronger. And I only believe that we can actually make it stronger together, between patients, families, caregivers, staff, public, citizens, everybody together. What I think is important is that the two things are focused on is access and choice. And what does that look like? As I said earlier, as somebody who's accessed care in multiple different areas, the one thing that I will say is that it is challenging for me when doors are shut and I'm not allowed to have a choice. And that is the challenge for me as somebody who has experienced care in many different countries. So yeah, I suppose that's the one thing I would say.
And we're out of time, so I want to thank you for using that powerful voice for kicking down lots of doors. Advocating for everyone here and in the general public makes a difference. And thank you. It's a really powerful story, and I think people learned a lot. So thanks for joining us here
Thanks
today,
for your
Claire.
time. Thanks, Andrea. Thank you.
So we're going to move right into another panel discussion. Like Claire, I need my notes. So I'm just going to move right into introducing our next panelists and more questions. And instead of one, I'll have 4 people joining me. So let me start with Raymond McArag. He's a primary health nurse practitioner with Parkdale Queen West Community Health Centre in Toronto. And they have this really nifty van. You'll hear about it. Next, we have Dr. Nell Wyman, Acting Chief Medical Officer for the First Nations Health Authority here in BC. Also joining us is Adrian Gear, Registered Nurse and President of the BC Nurses Union. And finally, Matthew Chow, Chief Mental Health Officer with TELUS Health. So welcome to all our panelists. Come on up and let's chat. How are you? Yeah, good. Nice to see you. Welcome. Great. So thank you, everyone, for being there. Everybody has a drink but me. I'm jealous. but that's my own fault. So maybe I'll start, I'll start with you, Adrian, if I could. Adrian Gear, welcome from BC Nurses. You know, one of the most urgent challenges in healthcare, and we've heard this all day over and over again, is shortage of health professionals like nurses. So could you just weigh in on this? You know, this isn't only a problem in BC, it's everywhere, but what are we doing about this? Can we solve this?
Can we solve it? Yes, I think we can solve it. Certainly, well, I've been nursing for 30 years, and when I first graduated, there was actually a job shortage. And so 30 years later, we are some days in a crisis, and it's not just in BC, it's actually a global problem. Can we solve it? Yes, we can. We have to do better forecasting. We have to domestically educate more nurses and other healthcare professionals. We have to recruit aggressively, but ethically from other jurisdictions. But we also have to create quality work environments where people can actually practice and care for the patients that deserve the care. And right now, that's certainly, I can speak for nurses, that's not our experience. On any given day, there's simply not enough nurses to deliver the care that patients require and deserve.
And I'm going to come back to that care environment later to ask you more. But I'm going to go out on a limb and guess that as a union leader, you're not overly enthusiastic about private care. So I think I can make that assumption. But we also see a lot of nurses fleeing the public system to work in private, to work in agencies, in clinics. How do we explain that paradox?
Yeah, well, certainly many of my members that are actually so unionized, nurses that work in health authorities that are electing to work for agencies. You know, I think the working conditions have gotten to a point where it's very difficult. But what's the challenge is really around the work-life balance. Nurses being required or mandated to work overtime, not having the ability to get a day off to attend, you know, a milestone celebration for a family or friend, constant redeployment, all the administrative tasks that fall to nurses because nurses, you know, pick up the slack for a lot. And so, yeah, it has created a situation where nurses, so that they can hold on, are looking at other options. And, you know, they're being paid a lot more money by private agencies. But really, it's the taxpayer that's paying for that, right? And so when we look at the stewardship of public dollars, as a taxpayer, I think people should be pretty concerned that nurses are being paid, you know, 2-3 times as much to work for an agency. Now, granted, they're not getting a pension, they don't have benefits and things like that. But it is, I would say, a means for people to stay in the profession currently. And again, if we could go back and create the conditions, if we could spend that kind of money on private agency nursing, why can't those investments be made in the public system? We have highly thank you. You know, to become a registered nurse, for example, it's a minimum of 4 years. To work in some of the specialty areas, it requires another 2 years of education, not to mention experience. And why aren't we investing? Why aren't we investing in keeping those people in the system and instead of just sort of letting them go? And so I think that, again, it comes back to the work environment. It comes back to nurses being able to have some work-life balance. But I don't think that you know, on any given day, I would say that we are in a state of crisis, but I don't think we're beyond repairing this. I think strategic investments in healthcare, treating the human resources, whether it's the nurses, whether it's, you know, the care aides, whether it's the physicians, we can do better by the people that work in the system. And I think they'll stay or come back, hopefully.
Yeah, and I think that's an important message. Everything's fixable. We have to figure out how to fix it, and that's what we hope events like this are helping us do. So Matthew Chow, you're kind of at the other end of the spectrum. You're at TELUS Health, a private provider. I want to ask you a question that's come up many times today. You know, are private providers, are they undermining the public health system, or are they kind of shoring it up at the edges?
Yeah, so I can say unequivocally that myself and all the colleagues that work with me, we support an equitable, universal, publicly funded system, full stop. And so I see some folks in the audience have a picture or a sticker that says, "I stick up for public health here." Can you give me one of those? Because I support publicly funded healthcare. And so do my colleagues. But what we see is that our publicly funded healthcare system is sick, and we need to do something about it. My daughter has a medical issue very similar to Tamara Taggart's daughter, and thank you for sharing that. She was referred to see a specialist when she was in grade 3. She's in grade 5 now and hasn't been seen yet. We haven't even been given an ETA for when she will be seen. And I'm actually quite alarmed that Tamara has said that it took her 36 months. So I guess what I should expect is that when she's in grade 6, she'll finally get diagnosed. That's the kind of stuff that keeps us up at night. That's the kind of thing we want to help with. And so to answer your question, no, in the private sector, we do not want to undermine the publicly funded healthcare system. We want to shore it up. We want to support it. We want to bring the innovation and energy of the private sector into the public sector, into the tent, be part of the system to shore it up. That's what we're about.
Now, you specialize, your area is mental health.
It is.
That's an area where we do particularly bad in the public system.
Yeah, don't get me started about how publicly funded mental health care is doing.
Why do we have to turn to private providers to do mental health?
Well, the fact is we already turn to private providers to do mental health. Anyone seen a psychologist in here before? That's private. Counselors? Private. Addictions care? Private. Addictions beds? Private. We already have a system that relies a lot on private sector. And so my argument would be, why don't we integrate that better? So we know we already have this strictly speaking about mental health care. I'm not a surgeon like Chris Hogue, so I won't comment about surgeries, and I'm not a public health official like my colleague Nell here. But strictly speaking about mental health care, we already have this private system. Why don't we bring it back, bring it closer into the fold, and have stronger public-private partnerships so that we can provision equitable care based on people's need rather than their ability to pay? And we can do that. Within TELUS Health, for example, we have examples where we provide publicly funded, privately delivered services. And my colleague, Dr. Ross, pointed out that distinction, right? Publicly funded, privately delivered. The patient pays with their health card, not their credit card. I love it. I love that. We're doing that right now. Hundreds of thousands of British Columbians in this province right now are receiving publicly funded care through TELUS Health. Let's build on that. Let's find a way to build on that so that we can have even more equitable access, more universal access, so that people are not waiting 36 months to get a diagnosis. I don't want my daughter to be in grade 6 before she gets seen.
And we're going to come back to talk about one of your interests. You also do partnerships. We'll come back with Raymond to talk about that in a minute. But I want to bring in Dr. Nell Wyman first. The First Nations Health Authority is quite a unique thing that exists in BC. It doesn't exist in other provinces, essentially a health region for the First Nations population. Can you tell us a bit about how FNHA works and why it's necessary?
Sure. So First Nations Health Authority just celebrated its 10-year anniversary, although a lot of the planning and decision-making around it happened before that. It was probably it is the largest self-determining decision that BC chiefs and health leaders have made in this province, and it was First Nations Health Authority, or FNHA, was established to ensure that the First Nations perspective on health and wellness was kind of, integrated with the healthcare that people were receiving. So we work in partnership with the other 6 health authorities in this province, so the Provincial Health Services Authority and then the other 5 regional health authorities. And we have a very unique governance structure. So we are kind of like a stool with 3 legs. So FNHA is one of the legs of that stool, and we have a board of directors. We have what's called the First Nations Health Council, which are representative of the 200 plus BC First Nations chiefs of different First Nations in this province. And then we have the First Nations Health Directors Association, which are the health leaders or health directors in each of those 200 plus communities, representatives of that. And together, we have a tripartite structure to direct the programs and services and how we work for BC First Nations.
And this is, I think it's fair to say, this is one of the success stories of Canadian healthcare in the last decade. Why isn't this happening in other provinces with large First Nations Indigenous communities?
I think to a certain extent one of the things I think if I had a PowerPoint here, I would show you a map that, the different First Nations or the large First Nations groups don't necessarily correspond to provincial boundaries. And I think that's probably one of the biggest issues is, say, for example, the Cree Nation straddles not just the province of Alberta, but into Manitoba, Northwestern Ontario, and even a little into British Columbia. So it would be hard to sort of say, let's have a Cree First Nations health authority. I think that's part of it. But different regions in different provinces have been exploring a model similar to ours. And similarly, internationally, for example, people who are familiar with the New Zealand healthcare system, there's now been a newly established Maori health authority.
And there is a Cree health authority in Nunavik in northern Quebec, but it is very homogenous there, so it's easier, as you mentioned. And I'm going to come back later and ask you about private care in Indigenous communities, because there's a lot of interesting stuff going on there, but I want to get Raymond in on the conversation. And Raymond, I've saved you for last because you've kind of done it all, right? You've worked in private boutique clinics, you've worked in the public system, you work in a very interesting clinic in Parkdale, as a part of Toronto, where a low SES region, and you also have this partnership with TELUS. So someone who has done all this stuff, what are your thoughts on what's the right mix of private and public health?
It's a big question to answer. I think if we had the true answer to that, we wouldn't be here today. But
that's why I invited you.
In my opinion, I think there is a great space for private-public partnership. And I think the potential is great. However, we have...
Just hold on a second, I think you're...
Untapped.
Yeah. Okay, I think they fix you.
We have not tapped into that potential just yet. And I think there are certain factors that play into a very successful and a long-term partnership. One of those things being ensuring that you choose the right partners to partner with and collaborate with. And what I mean by that is ensuring that you share the same social values or social missions, maybe similar mandates. So I'll give you an example of what our partnership looks like. The partnership is between ourselves, Parkdale Queen West Community Health Center, which is a publicly funded organization. We partner with TELUS and TELUS Health for Good program. We all know what TELUS does. TELUS Health for Good also leverages their technology to be able to connect disadvantaged populations. And so they do this by helping us to deliver primary care on the streets, utilizing a mobile clinic. And this mobile clinic has the awesome technology that TELUS provides, while we, the healthcare clinicians that are experts in providing care to our marginalized populations, are staffing these mobile clinics. And so the third partner in all of this is UHN, or University Health Network, and their social medicine program. So their mandate is to look at healthcare from that determinants of health and tackle those determinants of health and address those determinants of health. And again, their mandate is also to provide access for those that are disadvantaged. So you see, the three partners have that same goal, that same mandate in mind to be able to deliver the care that we all require. And so we're doing this simply because, well, in Parkdale, we do have, as Andre mentioned, a big population where they lie in the lower end of the socioeconomic spectrum. In addition to that, however, I think it's also important, the folks that we're trying to provide access to are, again, they're marginalized. And so we need to ensure that the barriers are minimized as much as possible. And what I mean by that is we need to ensure that we uphold the 5 principles of Medicare and continue to do so. Because if these people are already disadvantaged, you expect them to pay when 50% of their pay, actually more than 50% of their social assistance checks, goes towards their rent. And they have minimal money to purchase food, clothing, and even transportation are among some of the things that are required in order to even to get to an appointment, for example.
And you have this nice fancy bus that drives around
Yeah.
with the TELUS logo on the side.
Yeah.
But What I find fascinating is when we talk about private healthcare, we often think, well, private healthcare is for the rich, but you're providing to the poorest of the poor.
Correct. And I think that's why 3P works, because you've got the partners in place that specialize in the right things. We provide the specialty care that our marginalized clients need, and Parkdale Queen West Community Health Center has a more than 50-year history of providing team-based primary care, and we continue to do so. That is the third principle that I think that needs to be emphasized in any partnerships, team-based primary care. Because, as was mentioned in the room earlier, lots of burnouts happening there. Well, if you have a team that's providing care to folks that are in need of multiple avenues of care, well, you're spreading out the burnout. You're also spreading out the access to the healthcare providers. And what I mean by that is one individual can have access to more than one healthcare provider. And so I don't necessarily burden my colleague for all the care. Well, maybe there's the dietitian that you can also go to. Maybe there's the counselor that you can also speak to. This team provides that care from a non-monetary perspective. You still use your OHIP card, just like Dr. Chow had mentioned, but we provide you the proper care that you need in order to lift you up from the ground up.
And we'll come back and ask you in a couple of minutes about, team-based care. Can we have a mix of private and public? So think about that. But I want to go back to Adrian. I promised to give you a chance to talk more about the work conditions. And I always come back to this famous quote, the conditions of work are the conditions of care. So this matters to patients, right? We all say, oh, well, doctors always whine they're not paid enough, nurses. But this ultimately matters to us as patients.
Yes, absolutely. If there aren't quality practice environments where nurses and other healthcare professionals can meet the needs of the patients, then what results is moral distress, burnout, and people make choices to leave a system that desperately needs to have us in it. So yeah, I can't underscore enough that the quality work environment is so important. Currently, my membership is experiencing, increased injury rates, both psychological and physical occupational injuries due to the working conditions.
And if I could just interrupt, because I've written about this, nurses have a higher injury rate than, say, police officers and firefighters. This is a physically demanding work.
Yeah, no, it's very significant. Our long-term disability rates are going up. But I guess sort of taking this back to the discussion around, private versus public, it's the same finite pool of resources, right? And so how do we invest, how do we support a system so that the people that are working in it can provide the care that patients need? And so this, is a very interesting conversation, and I just think there's so much more that we can do to ensure that the system is there for everybody, that it is accessible for people, that patients feel that they're getting the good care, the practitioners, the clinicians, whether it's the porter, whether it's the emergency room physician, that people feel good about the care that they're delivering, and there's lots more that can be done to make sure that happens.
Great. And Matthew, I want to come back earlier. Tamara Taggart, one of the things she said was that, patients don't care if their care is provided publicly, privately, as long as they can use their card, right? So that was her sort of patient perspective. What about an industry perspective? Do you have that same outlook that it doesn't really matter?
Yeah, well, if you're, so I've been a patient, and I was a patient with what they call an elective surgical issue, and I agree with all the colleagues, all the folks in here that said that elective is a little bit pejorative. I didn't feel elective. I couldn't sleep. I was symptomatic, and it wasn't fun 2.5 years that I spent on a wait list for that procedure. And you know what happened? In the middle of the pandemic, I get this lovely phone call, and it's the government calling me and saying, Dr. Chow, actually they didn't call me doctor, which is good. I don't want preferential treatment. Said, Mr. Chow, it's your lucky day. It's time to get your surgery. And I'm like, great, where am I gonna get it? I'm gonna get it at a private facility. I'm like, what? How's that? said, yeah, the government has released some funding to publicly fund a privately delivered surgery. If you decline, you're probably going to be waiting 3-4 years. If you say yes, we'll book you next week. I was like, great. And I suspect that most patients like me would agree. I don't care that was, well, actually I do care, because I do care about publicly funded, but like, you know, at the end of the day, I got my surgery and I stopped suffering from my symptoms. That's what mattered. And the fact that it was publicly funded so I didn't have to pay for it was awesome too, because then it felt much more equitable. And that's, I think that is a great example of how this can work. Like, and it's happening. I don't know why it's such a secret that this is happening. Like, I'm a living example of where it works. Otherwise, I'd still be probably waiting for my surgery.
Yeah.
And this is especially true in things like mental health care, where there is like this huge pool of like counselors and psychologists and addictions workers that is in the private sector, and we could probably unlock by having that stronger partnership. But it's true in surgical services, diagnostic. We had a diagnostic imaging company CEO earlier on the panel, right? You know, there is that capacity in there, that relief valve or escape valve there.
And Nell, I want to come back. The FNHA has some partnerships too, specifically in virtual care. You also have, you know, roughly 200 independent nations who can choose to have private or public health care. Is there opportunity there for new partnerships, for doing things differently?
Yeah, I mean, I do think there's opportunity for partnerships, and I think there's also some challenges as well. So with regards to our virtual services during the pandemic, when a lot of services were either, you know, pulled back or severely restricted or stopped altogether for a period of time, you know, we saw a need for people to have especially primary care, including mental health services. So we stood up our own virtual services during the pandemic. So one's called the Virtual Doctor of the Day, one's called the Virtual Psychiatry and Substance Use Service. These are also provide team-based care, and the practitioners who work for our service are given or known to be what we call culturally safe providers. So that's the other aspect, I think, to all of this. So we have done a lot of work over the years in cultural safety, even before the release of the In Plain Sight report about 3 years ago now, which showed racism is widespread in BC's healthcare system. So we've been working in a number of different ways to try to change that. And so what we find is, you know, the other kind of angle to access is it's not just having a bricks and mortar building for people to go to or a mobile van for people to go to. First Nations people choose not to go to those services out of a fear of how they're going to be treated. They fear that they're going to be treated in a racist manner, discriminatory manner. And so that's a key part of access for us, is having people feel comfortable and know that they're going to be treated well in a culturally safe and humble way. So we set up those virtual services, but I think, you know, the other aspect about private care, I mean, I think the mobile clinic is a great idea and would work obviously for people in situations of vulnerability in larger or even some smaller but urban settings. In the BC context, it's really a challenge because we have communities that are so remote and isolated. You know, I think back to when we organized the COVID vaccines, the first shots, and it was like planes, trains, automobiles, boats, ferries to get the vaccines to these different communities. And the other thing about private services is that, you know, our concern, not just about the equity issues from a financial point of view, most First Nations, probably it would be safe to say, wouldn't be able to afford private care. Although that, again, I shouldn't stereotype. I'm sure there'd be some people that would be. But the other thing about ensuring cultural safety in private services, I think there's a lot less accountability in a private health health system or an enclosed system to ensure that those services are free of racism and discrimination.
We heard in one of our previous events about an initiative in Alberta where they're building, private surgical clinics on reserves, essentially because they are self-governing. Do you see that kind of partnership or happening in BC?
Well, I think it's really hard for me to say because the vision of First Nations Health Authority is for healthy, vibrant, and self-determining First Nations people, families, communities, and nations. And so I'll have to leave that question to self-determination, because it really is, if a nation decided or a group of nations decided that that's what they wanted to do, obviously our role is to support them no matter which way that they decide to go.
And Raymond, I want to ask you a question similar to what I asked Nell. She has a success story, it hasn't been copied. Why don't we have these mobile clinics everywhere? I know there are a few around the country, but why don't they exist in every low SES area?
Well, you're absolutely right with the mobile clinics being across the country. So it's not just in Ontario or BC. We do have them in other provinces as well. But that's also a really good question. My question, though, however, is why doesn't the government provide investments into these mobile clinics? However, when our private partners come and pick up the slack, well, it's almost like, and I hate to say this, but it's almost like Superman saving the day. The reason why I say that is because the marginalized populations that I've been serving for the last 20 years, you really see them down in the dumps. I took a ride out to East Hastings yesterday just to see what the situation here is like. And, it just breaks my heart because it's the same things that we see in Toronto. And so with these mobile clinics providing services to these populations and to these neighborhoods, we're going to where they're at. We know they're not going to come to the emergency department. We know they're not going to come into our clinic. So we come to you. And so if we're able to bring these services to these communities, well, that will help with these isolated communities, for instance, and then have these clinics ready and waiting and nimble. I say the word nimble because when we first got this mobile clinic, it was just at the beginning of COVID. The moment we got this mobile clinic, we took this bus out and vaccinated a great portion of the city. We did contact tracing for public health. We assisted with doing contact tracing, and we did these testing clinics day in, day out, every day for 6 months. Don't tell me that mobile clinics aren't effective, because they truly are. They do help the people that we're trying to bring up. And so if we can continue to provide investment in these awesome pieces of equipment, mind you, it's not perfect. However, it's a great start to provide services to those that need it the most.
Great. And I think Nell answered part of your question earlier when she said, we do have this obsession with buildings, right, with bricks and mortar. And the future of healthcare is really bringing healthcare to people rather than people going to buildings.
And I think it's the key word here is innovation. And so these mobile clinics, we had one mobile clinic when I started my career. One. And I said to my executive director, why can't we have one of those? Because we used to do outreach on foot. 20 years later, we get this awesome mobile clinic, and we're hitting more people, more neighborhoods, and providing the care that they need, period. So innovation, the more innovation we have, I think the better for our population.
And I'm going to ask you guys if you have any questions, but I want to ask Adrian about the innovation question. Why can't we give nurses what the private system is giving them? Why are we so reluctant to innovate within the public system? There's nothing we can't do that's done by the private sector.
Well, I think that's a fair question, and I think that is part of the way that we support and ensure that the system is functioning and accessible and providing the care that it needs to is through innovation. Absolutely. And I'm listening to this really brilliant example of this mobile clinic, but really, like, why can't that be in the public system? Like, I don't understand. And certainly, the members that I represent that do work in the downtown east side, you're right, they're out there on foot. They are setting up, sort of stations and clinics and things like that. We can certainly enhance the delivery of publicly funded healthcare through innovation. Absolutely.
And the beauty about, and I apologize for interjecting, my colleague mentioned culturally sensitive care. When we got this mobile clinic, that is the first thing that we considered. We wanted to make sure that this mobile clinic is welcoming to everybody that we try and service or that we want to provide care for. We actually carry SAGE in our mobile clinic.
Yeah, you do have a very large Indigenous population.
We do. We certainly do. Yeah. And so our clients come to us when they see this van, they see it as a place of respite. They'll come to us and say, hey, I don't want to go to Emerge because of X, Y, and Z. So can you provide the care so that I can at least take care of myself?
And Matthew, I want you to weigh in on innovation too. We always associate, well, innovation has to be private entrepreneurs. Why can't the public system innovate? Why can't they do what TELUS is doing?
Well, a lot of, and to credit the public system, by the way, I'm a public sector doctor. I worked in the public sector for decades. There's a lot of innovation actually that does happen in the public sector. And I think actually in this province, the Premier just gave out a bunch of awards to public servants for their innovation. And I applaud them for doing that. But here's a little anecdote. I'm sorry, forgive me for sharing this little story. So,
journalists, we love anecdotes, so fire away. Yeah.
Well, thank you for indulging. So the other day, I commissioned a colleague at TELUS Health to do something for me. And what I said to them was, could you create for me an AI chatbot that allows me to talk to it, tell the chatbot my feelings, and it should reflect back to me best practice in terms of mental health support. So if I'm not sleeping very well, it should give me a recommendation about how I can sleep better. If I need counseling, it should figure out that I'm a TELUS employee and recommend my EAP program. And so I just had a follow-up meeting with this colleague, and she was deeply apologetic. She was like, Dr. Chow, I'm so sorry. I've just had so many priorities. I wasn't able to really give this the full attention that I could. But off the side of my desk over this weekend, I wrote something for you. I'm like, oh, okay. Sounds pretty rough. She's like, yeah, it's I wouldn't even call it V 1.0. I'd say 0.0. Okay. So I look at this chatbot, and I am blown away. I tell the chatbot, yeah, I'm feeling kind of depressed, or I'm feeling, or I haven't been able to sleep. And it tells me, like, here's what I need to do for my sleep hygiene. Here's the EAP provider. Here's the phone number I need to call so I can talk to a counselor right away because I'm feeling down. This is a staff person in a private sector company that did this on a weekend off the side of their desk. Can you imagine if we unleashed that full innovation into our healthcare sector today? If we gave her the commission to actually do this properly and make this accessible to every British Columbian, every Albertan, every Saskatchewan, every Canadian, if we actually properly supported that innovation and welcomed it rather than being fearful of it, could you imagine what we could accomplish together?
Yeah, there's lots of promise for AI, but we have to also make sure it doesn't perpetuate the problems we have in the system. It doesn't. It can only scrape the data we have, so we have to be careful it doesn't perpetuate biases, for example, that exist in
Absolutely, which is why it's so important that the people working on this project, and I'm proud that my team is like 70% women and 44% racialized, because your team needs to look like Canada in order to serve Canada and to serve Canadians, and that's critically important for us too. And so I'm glad you raised that point.
Okay, so time for a couple of quick questions. I think they put the lights up. Oh, I can't choose. How about here?
Right. The ugly lights.
How about right here in front? Yeah, go ahead. He'll bring you a mic. Yeah, right here at the. Okay. Just talk. Yeah.
Hey there. I'm Tuesday Andrich. I'm one of the co-chairs on the steering committee of the BC Health Coalition. I have a question for Raymond, actually. He was talking about P3s, public-private partnerships. And so we know that Auditor Generals, when they have done audits of P3s, when they examine them, they find that the P3s cost more than traditional public projects. They use questionable methodology, they lack accountability, and they do not transfer risk to the private sector. So I'm just curious, are you aware of the Auditor General report in Ontario that shows P3s cost 16% more than traditional publicly tendered projects? And what would you say in response to that?
Well, to answer your question directly, no, I'm not aware. However, we've done our own evaluation on our mobile clinic, and the evaluation was performed by University Health Networks, UHN. social medicine program. And these are colleagues that have post-grad degrees in research and what have you, and blah, blah, blah. Research findings, typically, our research findings for a mobile clinic are very positive in that one of the things that we see, as I mentioned earlier, clients see our mobile clinic as a place of safe haven. They come to us because they know we are non-judgmental. We provide the care that our clients deserve. We provide monetary things to assist with the determinants of health, i.e., you don't have money to go to an appointment, well, we'll give you a couple of tokens. You don't have enough food vouchers, or you don't have any money to purchase food until your next check comes in, well, we'll assist you with some food cards. So in essence, the short time that we've had the mobile clinic has been quite positive. And so despite the fact that the Auditor General indicates that it might be 16% higher in terms of cost, well, if you look at it from a humanistic perspective, is there really value to somebody's life? Like, you know, I think the answer to that is a short no, because most people, you know, we value our lives, and you know, we consider it as priceless. But nonetheless, I think the fact that we've come up with an evaluation that shows that mobile clinics are quite effective with the marginalized populations that we do serve will continue to do so as long as we're reaching and hitting our mandates. So.
I'll just add, the Auditor General studied these large infrastructure projects, a little difference between building a massive hospital and a van.
Yeah.
So I think it's slightly different. But
the cost is much,
yeah.
And I think I'll just quickly add that one of the roles of my office at FNHA is we track health indicators over time. And so we see that there are definite gaps, for example, in life expectancy. And so the current system, or as it is not serving First Nations people well, because we're not seeing improved health outcomes. So in addition to the qualitative nature that people feel safer and more welcome and more helped, we actually are tracking indicators over the next 20 years to look at closing those health outcomes by improving health services.
Great. Lisa, do we have an online question? I know there's lots here, but I don't want to forget the online audience. There's lots of them. So.
Yeah, for sure. There's a question for Adrian asking, what do you mean by ethical recruitment of more nurses across Canada?
Yeah, no, for sure. I mean, there's not only a nursing shortage here in BC, it is across Canada, it's global, actually. And so, you know, Canada relies on recruiting nurses from other countries that too are having extreme nursing shortages. And so we really have to, there's an ethical framework that's, it's actually the World Health Organization, and it's just like, that's just really important to be mindful of because there's big recruiting drives and things that go on, but going and sort of like poaching nurses from other jurisdictions that are also struggling, there's an ethical element that has to be considered.
Yeah,
Thank you for the question.
There's an example recently of Canada poached a whole bunch of nurses from Ghana, a very small African country, pretty well decimated the workforce.
Yeah.
So I don't know where the mic ended up, but somebody's choosing for me, so. Okay. Yeah, go ahead.
Yes. Hi, my name is Peter Rohr. I'd just like to ask, particularly you, Andre, I've been reading for years your articles highlighting what you continue to call a crisis in healthcare in Canada, and we all know that the data point of the shortage of doctors for people having doctors who are primary care doctors is acute. But my own experience as a patient is I was diagnosed with congenital heart failure 7 years ago when I was 62. My care was excellent, and since then I've run 14 marathons, so I just want to counter that I understand there are gaps in the system, but I think that it's not accurate to portray that everything is bleak in our public healthcare system. And so really my question is it really useful to characterize what we have as a crisis? Because a crisis, as we know from the way that governments around the world respond to the pandemic, is not conducive to very good long-term planning. Crisis mentality leads to crisis reaction, like designing an ArriveCan app that costs tens of millions of dollars and does nothing. So I just wanted to ask if it's really useful to call it a crisis rather than looking at trends that need to be responded to in a systematic manner rather than choosing a easy solution like privatization.
Yeah, so if the question's for me, I'll start. I'll say I use that word selectively. I think that I always say that if you're in the right place at the right time in Canada, you get care second to none in the world. There's no question. But there's no question we have a serious access problem. 6.5 million people without a primary care provider, months of waiting for access to surgery. It's great that individuals, and that most individuals without question get good care, but most isn't good enough. This isn't pinochle, this is healthcare. This is people's lives, you know, like Claire said, it's life and death. So good is not good enough. It has to be excellent care for everyone. We can't leave people by the curb. So that would be my short answer. Matthew, as someone who's been a primary care provider, do you want to weigh in on that one?
Well, I can't call myself primary care provider. I haven't had that privilege. I've been a mental health provider, but I've led doctors of BC
What's more
in this
primary?
province. It is a crisis. I've had colleagues dying by suicide because of how bad it is. And my sister's a family physician, and she's like totally burned out. Like she can't keep staying up until 1 or 2 in the morning doing paperwork. So I apologetically beg to differ in that I would characterize it as a crisis. I don't think that's an exaggeration. Like Andre, I would not choose that word flippantly. It's rough out there. That being said, people like your members are heroes. People like your colleagues are heroes. People like Raymond are heroes. They're actually out there doing their very, very best. But despite healthcare workers' very, very best, they are burned to a crisp right now, and we need to find different ways to support them.
Right. And it looks, they're giving me the hook. They're telling me I'm out of time. I'm sorry. Maybe grab some of our speakers in the hallway when we wrap up. But please keep clapping for our wonderful panel, and as they make their way off, thank you again.
Absolutely, thank you.
Oh, thanks.
So as our wonderful panelists, Raymond McCarrig, Nell Wyman, Adrian Gear, Matthew Chow make their way off the stage, I'm going to ask you to do one final poll. And this is a question with multiple choices to answer, and it's a tough one. What is your view on BC's current mix of private and public care? Maybe we should ask you to write an essay, but we just have a poll. So we'll see what we get when we're doing that. What is your view? Oh yeah, there it is. There it is, your view on BC's current care. Okay, well, let's move on. We'll analyze the polls in our final report. So blue and pink, we're not seeing gender today. It's all just one. So there you go. So now, just to wrap up, to summarize a few key themes from the day, I want to welcome to the stage Dr. Jeff Blackmere. He's Executive Vice President of Global Health and Chief Medical Officer with the Canadian Medical Association. And Jeff, come on up and join me for a few final comments.
Thanks very much, Andre. On behalf of the Canadian Medical Association, I just want to thank our partners at the Globe and Mail for being such a great partner on this important initiative. And I really want to sincerely thank all of you for taking time out of your busy days, your busy schedules to come today to listen to the conversation and to share your thoughts with us. It's very valuable. The CMA represents the physicians of Canada, and we advocate on behalf of the medical profession and our patients. We previously facilitated national conversations on very difficult, divisive, and controversial topics like medical assistance in dying and the legalization of cannabis and its health impacts. These are difficult conversations to have without a likely consensus, but it's important for us to discuss them openly, transparently, and honestly in venues like this. We are a proud sponsor of this series, and this is one part of a larger body of work that we're undertaking on this issue. Yesterday evening here in Vancouver, we hosted a really insightful and important focus group with persons with lived experience to hear about their perspectives on these issues. And this evening, we're meeting with British Columbia physicians to hear their thoughts and how they're seeing some of these issues on the front lines. We have consistently been hearing a lot of the same hopes and concerns that we've heard here in the room today. What we know above all else, and what we have clearly heard this morning and this afternoon, is that our patients want and need access to high-quality health care and that our current system is struggling to provide this. And like some of my colleagues and friends, I do believe that we are in a crisis situation. This is different. I've been doing this work for over 20 years. We are at an inflection point today that is very different than at any other time that I've been working on these issues. We also know, and this was also clearly reflected into the dialogue today, that Canadians and Canadian physicians care deeply about the concept of equity and the importance of equitable and equal access to healthcare for all Canadian citizens. Over the next few months, we will continue to travel around the country to speak with physicians and the public about these complex issues. We will be undertaking targeted outreach as well to equity-deserving populations and to those in rural and remote areas. Our goal is to make sure that every person in this country who wants to be a part of this conversation will have the opportunity to do so. And at the end of this process, we will be releasing a report outlining what we have heard. Our board of directors will also be reviewing our formal policy in this area. This is not a theoretical thought exercise for us. We will be taking action based on what we hear. You should know that politicians and other decision makers are watching these conversations very carefully, and we know that because they reach out to us frequently to understand what it is that we're hearing from Canadians across the country. So I want to thank you again for being a part of this initiative, and I want you to know that your input and your feedback are valued and will be reflected in our work moving forward. Thank you. Merci. Miigwech.
So thank you again, Jeff, for that summary. Again, thank you to the audience here online. Sorry we didn't get to all your questions. I guess that's a sign of a good, vigorous debate. There's still more to be said. Everyone who registered for this event will get a link to the recording in about 2 weeks, so watch for that in your email. The next event in this series of public-private analysis that's going on from the Globe and CMA will take place in Halifax on January 25th, and registration is open for that both in person and live. And thank you again, everyone, and safe home. Merci.